going to get started. If people can grab their seats. Thank you.
Welcome, everybody. I'm Peter Letzu, and I've got the great privilege of being the dean of what's the most beautiful law school in America. And I've said that since I've arrived here, but now I don't have it with me, but I have a magazine to prove it, that we are, in fact, the most beautiful, the best law school facility in the country, and that's on top of everything else that we all do so well. So it's great to have a great facility to feature our wonderful faculty and our wonderful students and everything that's going on here. We're particularly pleased to be hosting this symposium today. It's really a wonderful event for our community. It brings together an incredible number of stakeholders, all of whom are trying to make Memphis an even better place to live, learn, and work. And we're very, very proud to be a part of all of that process. We don't view our law school as an ivory tower. We really want to contribute to our community while at the same time finding innovative ways to educate our students. And this program is just one example of how we're doing that. Again, the main goal here is to contribute to creating a healthier community to live in, which is a great thing to do all on its own. But it also helps our students get a great legal education, meet all of you, and interact more fully with our community, become better lawyers in the process. So it's a great learning opportunity too. And I would say this is just one example of how we're trying to achieve those dual goals of educating our students and contributing to our community. We've got a lot of other things underway and some new things that we hope to announce very soon. And I'll just highlight a couple of those things. One, some of you may be familiar with the anti-blight clinic that we've just announced and started earlier this spring, where we have our students under the supervision of Professor Danny Shafson, who may be here somewhere or was at least out front. There he is to my right. Danny is leading a group of 8 students working with the city attorney to clean up blighted properties, clear them, clean them, and the students are, again, they're going to court, they're getting great legal experience, and they're making Memphis a prettier and a more pleasant and a healthier place to live in the process. We also have Amy's Healthy Homes Partnership, and many of you here are involved with that. That's working to make sure that codes are enforced and that our children are living in homes that are mold-free and healthy communities, so healthy homes for them. Another great thing. Hopefully, within a very short period of time, we'll be announcing a medical legal partnership in our community that'll put our students in hospitals to help with care decisions, help with legal matters that are going to contribute to better health care for patients, so overcome legal obstacles that are contributing to health care. So again, these are really, this is where we want to be focusing. Again, we want to do a great job educating our students. We want to give them great experiences, but again, we want to do so in a way that really makes Memphis, as I said, a better place to live, a better place to work, and a better place to learn. So welcome. We really are pleased to have you here today. Professor Campbell has put together a tremendous program for you, so I'm sure all of you are going to enjoy it, learn from it, and again, help us make Memphis a better place in the process. So let me welcome Professor Campbell and thank her for all she's done.
I'll promise I will keep my welcome remarks short to keep us on schedule. As people know, I'm going to try to keep us on schedule today. But I really thank you all for coming out. I know that there's some weather out there, but compared to the winter we've had, this is probably pretty easy weather. I'm hoping today goes better than yesterday went for my basketball brackets. It was a rough day. I don't know if anybody else had a rough day. I hope you did, because then maybe I still have a shot. But I'm hoping today's a little better. I just first briefly want to give a big thanks to, it really takes a village to pull together the symposium, particularly with me. And so the administrative floor, the second floor has been invaluable, especially Teresa Winkleman, who did the registration, and Ryan Jones back here, who's lovely and taking pictures for us, has helped with communications and marketing and getting the word out to get you guys in the seats today and have the lovely brochures and things like that. Caroline Gordon, who's in the front row with Ben Lewis, another one of our students. The Health Law Society has been fabulous. They helped you register. They'll be helping sort of help work the panels, and I'm so delighted that we have a new Health Law Society and that it's really growing and that we're able to partner with these kinds of events. So I thank them. I thank the Dean and all my colleagues for the support in growing the Health Law program. And I thank you for coming today and being part of our second annual symposium, something that's really near and dear to my heart. So what have you signed yourself up for, and hopefully we'll keep you for the whole day. Just to let you know a little bit about how this came to be and how the day is going to unfold. You've heard about the Healthy Homes Partnership and the Neighborhood Reservation Clinic. I went to the University of Notre Dame, hence why yesterday was almost a really tragic day for me. Wow. But at Notre Dame, there was the Center for Social Concerns, and they instilled in us that as we were learning, we could be serving in the community and learning while serving. And I thought that was such a powerful message. And that's part of why I wanted to be a lawyer. And so I'm so delighted to get to come to Memphis that, yes, has its challenges, but has so much opportunity. And to work in a law school that accepts and recognizes our responsibility and our obligation to partner with that community that we live in, that we study in, and our students can learn so much in partnering with the community. So the Institute for Health Law and Policy, that's our new formal name. The way we shorten it is iHelp, and it's iHelp Memphis. We really want to open our doors to have you in, but also open our doors and go out and engage with you to sort of address, how can law advance health, and how can we help provide policy solutions or policy research that can help with your needs. And the way that has really coalesced is around neighborhood redevelopment, the housing and environmental factors, and really a holistic vision of health. At the same time all this was happening, I had the opportunity to get to know the Robert Wood Johnson Foundation folks a little better. And related to that, we had an event in November where one of our keynote speakers, Bob Waller, who used to be the CEO of Mayo, and we're so lucky to have Dr. Waller in town, mentioned that 10 years from now, we're not going to be able to talk about community development or economic development in a place like Memphis without thinking about health. And that health is integrally related to everything we do, to how we walk, how we live, how we eat. I mean, everything we do in this community. If we're not thinking about health, we really can't effectively be thinking about community and economic development and vitality. And so when he mentioned that, it all sort of seemed to come together. And so I was delighted to read about Robert Wood Johnson Foundation's, focus on a culture of health, and how we have health in all policies, and we can really see how health is affected by so many sectors, and how it's going to take the community to make sure that we sort of advance and protect and safeguard our health while we try to develop and build a sustainable community. So the morning will kick off with Sharon Rorty, who will join us from the Robert Wood Johnson Foundation. You can see the slide up here, to talk about what do we mean when we say a culture of health. How are we defining that, and how can we be a part of that? After that, you may think, well, that's a great sort of foundation, but what does that mean for us? We're going to hear from two wonderful national experts, Marish Ash and Liz Tobin-Tyler, to talk about, here are policy tools. Here's what other communities have done that you can think about using. Here's the national model of a medical legal partnership, and how the healthcare community can partner with lawyers and others, public health, all sectors, to say how can we advance the health of a community. So they're doing it, they're experts, they've seen it done, and they're going to share their knowledge with us as part of a building block to a healthier community. The afternoon will pivot to the building blocks for a healthier Memphis. What is the culture that we exist in, and how can we advance our health? And we'll start with the faith community. As you well know, I'm sure better than me, I'm relatively new to Memphis, but the faith communities and the diverse range of faith communities we have here play such an important role in Memphis and in Shelby County and our region. So we've invited, not all, we recognize not everything is represented, we only have so many chairs and microphones, but we've invited some who are doing some really interesting things, some faith leaders who are doing interesting things around health, to share what they're doing and just make sure that we sort of call them, call to action with our faith community to partner with them to advance health and the development of our community. And then we'll end with assets. I really want today to be about, yes, we have challenges in this community, but we have so much opportunity and we have so many great people doing interesting things. So we're going to hear about, the environmental court, the Mayor's Innovation Delivery Team, the Healthy Homes Partnership, our land use, comprehensive land use planning efforts, and how health and policy are integrated within that. And we're going to say, if we have so many great things, how can we leverage those and make sure we're talking to one another? I see so many great things happening. I think just sometimes we're sort of siloed and we're not talking about how to sort of all collaborate and partner across systems, across efforts. And so we'll end the day. I promise I know by then you will be so sick of me and want to get out of here. So I'll try to be brief, but we'll talk about next steps. Because I recognize that this is just one day, and it really is the start to an effort. But we really want to be a place that we will convene. We will do whatever we can with the Institute and the law school to partner with you to continue forward the networking and the discussion that starts today. With that, I am going to turn it over to Yvonne Madlock, the director of the Shelby County Health Department, who I am delighted is going to introduce our first speaker.
Good morning, and thank you, Professor Campbell. And I know she is a stickler for time. I will take 1 minute of a bit of personal privilege. And on behalf of Shelby County Health Department, on behalf of all of us that are working collectively and collaboratively to improve the health of the community, I just want to really take just one moment to thank the University of Memphis, the School of Law, Dean Letsu, Professor Campbell, the Institute, and for their energy, their vision, and the commitment of resources and talent that they've brought to these issues that are really going to accelerate our health improvements here in Shelby County. So thank you. This is the second symposium. I think it's very important. So with that, let me get to my specific task for the morning, and that is to introduce to you our first speaker of the morning. That is Sharon Z. Vorty. Ms. Vorty, as you can see from the slide, and as Professor Campbell mentioned, is a senior program officer for the Robert Wood Johnson Foundation. She is an environmentalist and a planner by training and by credentials. She holds a BS degree in environmental science from Stockton State College, a master's degree in city and regional planning, and she is a member of the American Institute of Certified Planners and a licensed professional planner. But most importantly, she is to me, she is a very dedicated and highly achieving public health professional and public health practitioner. She has managed to merge all of those credentials and experiences into advancement in the work of public health. She is innovative and has extensive experience in the practical implementation in both the public and the private sectors. She served as principal planner and project manager with several large environmental management firms responsible for environmental growth impact studies for major land development in the New York area and New Jersey areas. She has managed a multi-billion-dollar capital improvement program for the North Jersey Transportation Planning Authority. And her skills have been recognized and demonstrated by her appointments and service on several national boards and task forces. She was appointed by the U.S. Secretary of Department of Transportation to the Federal Safe Routes to Schools Task Force. And she served on the American Bikes Board of Directors. She's been on and served on the Safe Routes to Schools National Review Group and serves as the Regional Plan Association's committee member to create a long-range strategic plan for the New York metropolitan area. So bringing initiatives to scale is something with which she is very familiar and has great experience. In her current role at the Robert Wood Johnson Foundation, her major focus has been on children and obesity. She uses her expertise in demonstrating the impact of the built environmental health outcome by helping communities make a connection between health improvement and urban design, transportation, housing, and environmental policy and investments. I'm very pleased and honored to introduce to you our first speaker of the morning, a true planner and public health professional, Ms. Sharon Vorty.
Thank you, Yvonne. That was wonderful. I am so pleased and honored to be here today, and I want to add my thanks and congratulations to Dean Letsu for bringing this school together, and to Professor Campbell too for having the foresight to come here, to come to Memphis, and to make this school everything it can be, to have an Institute of Public Health, to have a clinic on neighborhood preservation. It's just so wonderful, and to put it in this building, the U.S. Customs House and the Post Office, the House of the People. And now, as a law school, and to focus on public health, again, as a house of the people, sitting it right on the river, where you can look out on the river and look across the city. It's just wonderful. And I have to say that I watched the city in the years between 2008 to 2012. I watched it grow and develop, and I knew something was going on. The reason why, and I was here quite frequently. My son is a graduate of Rhodes College. When I got the invite to be here today, I was just, and I think it got passed on to me because I talk about Memphis a lot at the foundation as one of those cities with the little engine that could. That things are happening here. That yes, you have your challenges, you have your problems, but things are happening. And just as I watched this law school be built, in a sense, it was here, the building was here, but I watched the improvements, and I kept thinking every time I walked past it, wow, that's great, it's downtown. You know, again, house of the people. I want to get in there someday. So yesterday I got in here. So thank you, Professor Campbell. It was truly a pleasure, a treat. Again, it's just great to be here. I'm here only for a short time, but I'm coming back because I want to walk around the city again and see what's happened since, I guess the last time I was here was 2012. So, and I had to walk around back here, so I hope that's not too distracting to anyone, because that's what I do. I move around a lot. So let's get on with the show, as they say, right? As you may already know, or not, the Robert Wood Johnson Foundation has spent the past 40 years working with people to take on the major health and health issues of our time. Now with the Robert Wood Johnson Foundation, we've embraced a vision of working alongside everyone in America to build a culture of health in this nation. And throughout my presentation, I am going to say everyone and all, because that's what this is about. I mean everyone. The foundation is everyone. So let's start. I know it's early in the morning, but I want to see if everyone's awake. Who can tell me where this picture was taken? And double prize if you can tell me when. 2011.
Riverside Drive.
Riverside Drive's there, because there's lots of Riverside Drives, so I was just wondering if that would throw you off. So yeah, I was here in 2011. I was here. I checked into Marriott Hotel downtown the night the river crested, and it was phenomenal to see that river come up over the walls, you know, the riverbank, and up over onto Riverside Drive. And in fact, we even hit Beale Street. That was phenomenal. What this picture reminds me, and perhaps all of us, is that for some people, living in overwhelming situations is an everyday experience. For others, an experience like this is a sudden and unexpected curveball. But our ability to survive the disaster is closely related to the social, physical, and environmental determinants of our health. That's something. How about this building? Right on Beale Street. Silky Sullivan's, I didn't know the name of it. But I watched this building, and the girders are always there. The steel girders are up there, holding the building up. And it's a beautiful facade. But too, it reminds me that it's the supports around us that make us stronger, healthier, and more able to survive. That's important. So what is a culture of health, and why do we need one? Consider this. Culture filters every aspect of our everyday life. It is what we think, feel, and care about. It's how we learn and how we teach. It's how we relate to one another. Memphis has a culture, right? It's about great music. It's about great food. It's about the great people. Memphis, the city of Memphis, the culture of it is celebrated in over 1,000 songs. You know, it's incredible. I think it's the most sung about city, you know, in our country. That's because it's a culture. Now, picture of being healthy as you can was a part of our everyday culture. Baked right into the very core of the American experience. What if claiming, reclaiming, or sustaining health was a priority for everyone, no matter where you live, how much you earn, what you do, or where you come from? That's what we mean by a culture of health, to build a national culture of health that will enable all to live longer, healthier now and for generations to come. That's what we mean by a culture of health. Now, this is a big country made up of people who define health in different ways. For some, it might mean running a marathon. For others, It may mean being able to ride their bike to school on safe streets, or maybe in Mud Island or Overton Park. Maybe it's participating in the Eco Egg Extravaganza at Shelby Farms Park on Easter weekend, right? For all of us, it should mean going to see a doctor who asks what your life is like outside the clinic, or knowing that your kids are getting nutritious food at school. We all have a different understanding of what health means to us. But we also all know one thing for sure. Being as healthy as we can helps us lead more productive, prosperous lives. And that is something we should all value and all be able to take advantage of. Good health helps people, helps everybody in our workforce thrive. It helps makes businesses more competitive. It keeps our military prepared to defend our interests at home and abroad. Caring about the health builds neighborhoods and cities, and I think that's what this school's about, with green space and affordable public transportation. Caring about health means reducing violence and making sure our kids can enter school strong and ready to learn. Now, to make that vision a reality, we have to do more than think big. We need to act big together. Because you and I both know we are up against the challenges that we face. In today's America, too many people's health is tied to how much money they make, how much school they've completed, and the neighborhoods they live in. People's health has a lot to do with individual decisions they make, that's for sure. But the choices that we all make are based on the choices we have. We don't all have equal opportunity. Too many of our children are still overweight or obese, and that means they're facing the specter of a lifetime of chronic disease. In fact, right now, a shocking 75% of America's young adults are too overweight, too poorly educated, and too tied up in the criminal justice system to serve in the military. And research warns that if we don't do something about our kids' weight now, they will be the first generation in American history to live shorter and die sicker than their parents. When you look at the big picture of America's health, we aren't as healthy as we think we are. One of every 2 deaths in this country is still linked to chronic diseases like diabetes, heart disease, and stroke. And I don't need to tell you, that is just too many, and it is preventable. In today's America, we spend too much money on healthcare to get too little in the way of results, despite shelling out $2.7 trillion on healthcare. Let's take a look at that. Let's talk about spending money on healthcare. Here's a picture of the U.S. compared to other countries globally. So 30 years ago, we were at the top, tied with Denmark, close to several other countries in terms of what we spend. Now, we are 50% higher than country number 2 in terms of our spending, not in outcome, in terms of our spending. And we are about 2 times higher than the average developed country. After 30 years of technological growth and policy changes, we have lost ground. We have lost it badly. And what does all that spending do for us? Well, we have a lower life expectancy than all of our peer countries. Those 2 lines, it's male and female, that's not us compared to everyone. But it's a flat line for us. This graph shows the U.S. ranking. As you can see, we are the last or next to last at almost all ages up to age 75. That's when we start looking okay. We move to number 1 by 95. Then our life expectancy is good. That's crazy, right? That means that we live the longest after most of us are already dead. Something's wrong with that picture. We cannot treat our way out of this. We're spending all our money at the end. We cannot treat our way out. We tried at $1 trillion and we lost ground. And as a result of all this poor health, our nation continues to lose $227 billion in productivity each year. Science tells us that 90% of a child's brain is developed by age 5. And we all know that adverse experiences and exposures to environmental toxins in early childhood can seriously affect health and well-being way into adulthood. That 1 to 5, that 0 to 5. There's so much science going on to tell us how important that is. Too many children grapple with serious issues in their daily lives, with substance abuse or violence in their homes. Too many worry that they'll not have enough to eat. That's what's known as toxic stress. And when kids experience too much stress in their earliest years, it can lead to higher rates of chronic disease. It can lead to depression, criminal behavior, and suicide later in life. That walk to school is scary, and they do it every day. That affects them over the long term. And the environmental toxins, too, can lead to asthma, learning disorders, and cancer. Every one of you in this room like that is tackling pieces of this complicated puzzle. So I ask you this. What if we all agreed to stop defining health in this country as simply not being safe? What if we started working together to get others to see how all of these different aspects are connected to health? What would it look like in America if everyone realized that health is everything? I know here in Memphis you are stretching your thinking. I know you are working to make the city more vital, that you have healthy homes partnerships, that you have partnered with the Urban Land Institute to address land use issues, that you have a grant from HUD for reviving the 50 square mile area around the airport. That is a huge opportunity to get it right from the beginning, to work with the partners, to build in health measures, to get a different outcome, to get a better outcome. I know you have a program for kids at risk for asthma. And I know you have been working to cultivate Memphis as a beautiful city since at least 1930. The signs tell us that in the riverfront right. And I know, too, that in 2014, you were designated a Tree City USA. And my guess is that wasn't the first time you were designated a Tree City. Right? I know that because I've walked through Midtown. And I know the canopy of trees in Midtown is symbolic of a culture of caring. And it's probably one of the prettiest places that you could walk through in the summer. And I know that here in Memphis, in May, is a beautiful time to be. That's why you have Memphis in May, right? It's a celebration of the good things here, how beautiful this is. Well, if you are to make the cultural shift to a culture of health, then you are going to have to work together broad sectors. There's going to have to be a realization that we are all in this together, and that we have to make the pieces come together. The tree canopies and the canyons and the streams and the sidewalks. It all has to come together. We have to calculate and we have to recalibrate it to make certain that better health is an explicit outcome for all, especially our most vulnerable populations.
No, I was going to say, sorry, in the middle of your thought. I think people might be having trouble hearing you.
Oh, really?
So I wasn't sure if you want that or you want the handheld mic. Choice.
Are you having trouble hearing me? Oh, I'm sorry.
We can hear you, but just.
Oh, okay. Should I put on the mic as I move?
Yeah, sure.
Okay, I'm sorry.
Sorry, I didn't want to hit the train of thought. My subtle was so. I was over.
I thought, oh, am I out of time? Well, I have things I want to say. All right. I'm sorry about that. And I did see a few people. I didn't know what that was. Okay. Okay. We need to start a movement from the ground up to change our culture of health into one that values health, promoting, sustaining, and safeguarding it. Everyone and everywhere. We need partnerships, the passion and the promise of colleagues just like you, just like everyone in this room, and your other colleagues that are not here. I know what you're thinking, that changing a culture based on a single idea, because this crazy lady from New Jersey is here, and she kind of likes Memphis, and she came and she said something about a culture of health. We're going to change the world. We're going to change the world in Memphis because of that.
You know, how do we do that? We don't have the money, we don't have the time, we don't have the resources, we're busy, all those things. I'm just worried about getting to my next meeting, right? Well, I'm here to tell you that it's been done before by people just like us. In 1962, a scientist and a writer by the name of Rachel Carson published a chilling book. It was called Silent Spring. Some of you in this room might remember it. It warned of the effects of chemical pollution on the world around us. In 1962, we filled our tanks with leaded gas. Remember that? Even in the 70s. We accepted that chemicals in our water and our air were just a byproduct of industrial advancement. No one had ever heard of the word environmentalist, let alone recycling. But a book started a movement. It also, I think, launched my career. I've been very influenced by this book. This book sold 500,000 copies. A few years later, we had Earth Day, and 20 million Americans rallied in parks, neighborhoods, and streets nationwide. People started asking, what could they do to make change happen? And they realized we each had a role to play, just like we do today. And they said if they could collect and repurpose all those bottles and cans and give that paper and cardboard another life, they'd be doing something to make the world a cleaner, better place. This is just one outgrowth of that revolution. Today, most of us do this without thinking. Our cities, towns, schools, they make it easy for us to recycle, putting containers all around, right? So much so, it's ingrained in our culture. If we don't recycle, we feel guilty about it, right? I know I do. It's like I'll carry around that plastic bottle. Where is it? That can, that newspaper. That was 40 years ago. It happened. So change can happen. It doesn't happen overnight, but it can happen. We change the way we think. Now I have another quiz for you. Think about this. What would you do if someone in this room got hurt? If I suddenly fainted, fell on the floor, what would you do? Right? Now, you'd call 911, right? 911 didn't always exist. Not if it was America back in the 60s. Back then, there wasn't a single number to call in an emergency, which meant that people injured on highways faced worse odds than soldiers in combat. They got no first aid before they made it to an emergency room, where they had the doctors had no idea they were on their way. There was no George Clooney there waiting for you, in the bay. In 1965, accidental injuries were branded the neglected epidemic, the leading cause of people in the first half of their lives. Imagine that. That was 1965. All right, it's a while ago, but still, that's change in our lifetime. It can happen. Someone came up with a simple solution, and it was 911. Proud to say the foundation helped fund that work. A single universal number and a system for summoning an ambulance with trained first responders anywhere in the country at any time. Today, even preschoolers know the number to call, right? It started with a problem, it turned into a solution, and it became a way of life. So we know that change is possible. 911, unleaded gas, recycling as a norm, smoke-free airplanes. All changes in most of there's some young people here, but in our lifetime, right? So now I'm going to give you a group exercise. You have 2 minutes to do this. This is called lightning public health, okay? I'm looking at Maris because she might say, you can't do public health in two minutes. I think you can. I want you to pair up the person next to you, and I want you to think of a change, a practice or a product that did not exist before, and you could define before as anything you want, and that exists now and has improved our life. You have 2 minutes. Time's up. Quick 2 minutes. I'm working off Professor Campbell's book. Keep it on time. 2 minutes. Okay.
Couple hands in the air. What did you come up with?
Back. Cell phones. Okay. And has that improved our health? Right? There's apps. There's apps on the cell phone that we can track our health. Over here. Fluoridation. Okay, great. Back here. Bike helmets?
Yeah.
And bike riding lanes, right? Public policy. Over here.
Medical alert.
Right. Medical alert. Over here.
Seatbelts and airbags.
Seatbelts and airbags. Great one. This is all public health. Anyone else? Over here.
Medical insurance didn't cover cancer in the 50s and early 60s.
Wow. Big. Here.
Child safety seats.
Child safety seats. Huge. Anyone else have a burning one they want to add? I'm sorry? Home testing kits. For? Okay. Everything that was named here are common. These all affect our public health. They didn't exist before, right? We can make this kind of change. We are already on our way to doing it. We have to think of it as health. It is all part of the culture of health, and it affects the lives of everyone. So thank you. From catalyzing simple behaviors to building the complex systems that support them. From all of us seeing a role for ourselves, individuals and families, communities and businesses, faith leaders and policymakers. That's what we all need to build a culture of health. The seeds of this idea are growing. We are doing research into what works, understanding and sharing innovative practices with communities in need. And by breakthrough collaborations across sectors and across state lines. We cannot do this in silos. Groups just like this one here today are triggering a culture change, and it's starting to work. And although you might not remember this catalytic simple behaviors, right? That's a sort of a foundation wonky speak. You might remember this. It's one of my favorite quotes from Van Gogh. Great things are not done by impulse, but by a series of small things brought together. Right? So in this next segment, I am going to relate the culture of health into the foundation, the Robert Wood Johnson's Foundation, walk, what I call our walk into community development. This is still a very new area for us. We're just pushing in. What we really think we can do is help influence how community development happens. Take that money that's going to be spent anyway, and it's going to be spent in community development, it's going to be spent in high need areas, and try to bake in health into all parts of it. How about this photo? Out to Mud Island, right? That capital. Short video.
A zip code is 5 numbers. It's meant to get mail to people, not say how long they'll live. But all too often, that's exactly what a zip code does. Millions of Americans actually live sicker and shorter lives than others just a few miles away. Some of us are likely to live 25 years less, or be 3 times more likely to have a heart attack, all because of where we live. A zip code is 5 numbers that can predict whether we are likely to suffer a preventable illness and influence how safe we feel in our neighborhood. A zip code is 5 numbers that says a lot about the kind of schools kids go to, whether we get daily exercise, our access to healthy food, and quality health care. America's future depends on the health of all Americans, which is why the Robert Wood Johnson Foundation cares about where we live, learn, work, and play, because that is where health happens. And we proudly support changes happening all across the country to break down the barriers to good health. A zip code is 5 numbers that should indicate where we live, not how long we live.
Where we live, not how long we live. often talk about going upstream to affect change, and we need to do that. That's where we get systemic change, right? But we know it is downstream where change needs to happen. So in 2008, the Robert Wood Johnson Foundation convened the Commission to Build a Healthier America to help us find ways to improve the health of our nation. The commissioners, a national nonpartisan group of leaders from both the public and private sectors, called for breaking down the conventional policy-making silos and creating opportunities for better health in our neighborhoods, our homes, schools, and workplaces. In 2013, the Commission reconvened, and they issued 3 recommendations as shown on this slide. And each of these recommendations are big in and of themselves, but they also are integrated, right? When we invest in young children, we also need to integrate health and community development. They are big areas each and of themselves, but there is integration across them. I'm going to focus a little bit on recommendation number 2. The Commission to Build a Healthier America recommended that we fundamentally change how we revitalize neighborhoods, fully integrating health into community development. Your zip code should not be a life sentence. We believe there are great opportunities to leverage influence and resources in community development. At the Foundation, we are trying to plant the seeds for a culture of health for all. But we know that low-income families face barriers to health, such as housing with lead paint, mold, and dangerous structural problems. Fewer places to exercise safely, and purchase nutritious food, and they have greater exposure to air pollution. Community developers and community finance institutions address many of these challenges, and I know that's going on here. At the Foundation, we are working with others to develop and promote the use of analytic tools and metrics that facilitate incorporating health into planning, financing, and implementing new community development projects and programs to foster widespread and productive collaborations. In the conversations, in the 24 hours we've been here, we've been having conversations about these tools and metrics, and I know you're going to hear more about that in the next segment. The outcome we want to achieve is improved population health and well-being. Health impact assessments are one tool that can get us there, but there are others. How many of you are familiar with LEED, L-E-E-D standards? Okay, some hands. So LEED standards were promulgated by architects. Again, one of those changes in the last 20 years, 2 decades ago, right? Before that, we didn't have it. And when it was first introduced, it was thought, oh, here go the crazy environmentalists again. You know, the tree huggers, they're trying to do something, and it may be, and those that accepted and thought it was good said, yeah, but it's for the people at the top. Well, LEED has gotten so popular that it's being baked into all buildings. Not everywhere, all the time, but it's happening. It's become the standard that, that buildings have to attain. So imagine if we could take that and develop a LEED standard for health. Health in all buildings, health in all community development. That's something that we're working towards. We're working with others to try to get that baked in. We think it's possible to work across sectors and take an intentional approach to health outcomes. So the story of this slide is policy, metrics, action, and investment, right? But I'm going to tell you a real life story. It's not in Memphis this time. It's in Phoenix, Arizona. An assessment for public housing redevelopment used de-identified health information from a nearby school because 75% of the students lived in the housing units, in the public housing units. The data helped the researchers understand the residents' concerns about asthma, air quality, and housing conditions. Although countywide statistics showed relatively low asthma rates, the school reported that more than half of its students suffered from asthma. Having identified this important health concern, the developer included new heating and cooling systems to improve indoor air quality and reduce asthma triggers. It could be that simple. And I'm not saying that it's still a public expenditure. It's an expenditure, but you're going to do these anyway. You're going to rebuild the housing. So it's that kind of thing, knowing the data, knowing what is happening in the community. That produces change. And being intentional about it. having your priorities set. The public sector has created a number of measures that drive financial incentives for institutions and organizations seeking to drive capital investments in local communities. There we go. Currently, these measures are poorly coordinated across government agencies, and they do not measure health. As a result, the incentives have not been used to promote positive health impacts in communities. To address this lack of coordination, we will be convening leaders from branches of the U.S. Treasury Department responsible for the oversight of community development activities to talk about the use of coordinated set of health measures. And we will support the generation of those health metrics at the local level in places just like this. Additionally, we see opportunity to include health in civic and regional planning to help drive those measures in those regional plans and capital development projects that we are doing. We are working with the Regional Plan Association, who's creating a new plan for the New York, New Jersey, Connecticut metropolitan region. We're working with them as sort of a pilot to see how can we build those health metrics in. And then we're going to take those lessons and hopefully help spread it with all your help. We won't do it alone. The foundation is a big health philanthropy. It has a lot of money, but we don't have enough money to solve all the problems. We have to take what we're doing and get it out there and help, again, leverage the resources, financial, the people, the influence of others. That's what we're trying to do. So investing in your community, keeping these four considerations in mind to maximize improvement in your community's health and well-being. It is about to know where the factors are that impact health, identify where there are vulnerable populations at great risk, to work collaboratively across the sectors. So as I wrap up my presentation, I want to come back to Memphis City, a beautiful and healthy city. I love this sign, and anytime I took a walk along the riverfront, I just always had to stop at it and really contemplate and think about what they saw back in 1930 and what they're doing now. I know that the Memphis City Beautiful Commission is still in operation today. I looked it up just this last week to make sure that it was. And its mission, does anyone know its mission? It is to transform and keep Memphis a beautiful, healthful, and safe place in which to live. You knew it in 1930. You know it now. We have to help them realize this mission. I got another quiz for you. See who knows this one. How many of you know about the Memphis City Beautiful Boy Scout Patch? Okay. You want to tell us about it? It exists. All right, I'll help you out a little bit. I looked at what the commission was doing. The commission, when it was started, was about keeping it clean, doing those little steps, right, to bring them together, to take an intentional approach to Memphis. Well, the Boy Scout Patch, the Memphis City Beautiful Boy Scout Patch, the purpose of the program is to encourage awareness and involvement in community cleanliness and beautification, as well as instill a sense of pride and responsibility of the environment. To qualify for a patch, the scout must participate in one Memphis City Beautiful activity and select an additional activity from 2 of the partners for a total of 3 activities. Now that's great. The community partners include the Midtown North Community Garden, Clean Memphis, and City of Memphis Storm Drain Management, because that's health too, right? The environmental partners include the Lichterman Nature Center, Wolf River Conservancy, the Greater Memphis Green Line, Memphis Botanic Garden, Shelby Farm, Sierra Club. What if we got the Boy Scouts, what if we got everyone in this room to create a culture of health patch? And we did the same thing. We not only did it ourselves, we not only took on one activity ourselves, but we worked with other groups, with other task forces, with other coalitions. And we didn't just sit in meeting rooms and talk about what we were going to do, but we made something happen. And we talked about the communities, the neighborhoods, the greatest need. Because the culture of health is about lifting all boats. So the Memphis, I know, is a beautiful, resilient city. It's with a shared culture that values good food, great music, and its people. That's what I talked about in the beginning. I've been a frequent visitor to the city, as I mentioned, since 2008, and I've seen change. I think sometimes when you're here, you don't see all the changes that happen. I've seen change. This is a city with great bones and many great assets. what I hope I've done for you today is to leave you with some thoughts and aspirations about working together across sectors to create a healthier Memphis, a Memphis where everyone has the opportunity to be healthy, where they live, work, play, and pray. Work together. I urge you to really work together, to use data, to be intentional. I want to tell your story in another city. I want to tell them what you did from 2015 to 2020 to 2024. I want to come back and I want to celebrate with you. Thank you so much for having me here today. It's an honor and a privilege. This is a beautiful city. It's warm, it's inviting, it's friendly. There's so much to celebrate here. But we do have to lift all boats, and we do have to value health. So thank you.
Anybody has questions?
Andrew?
What does the foundation consider to be some of the primary barriers to cross-sectoral collaboration?
Primary barriers to cross-sectoral collaboration. You know, a lot of it we're just used to. Public health works with public health. They're busy. They're giving out vaccinations. They're doing whatever it is. Every public health department is different, but they're doing what they do, right? The land use and zoning department, they do what they do, right? So we can go through department by department, sector by sector. They are used to working in their area. They're under-resourced, right? They don't have the people, they don't have the money, they don't have the time. And so even though you can come together like this, hear something, it's like, yeah, but I got to get on to the next thing, right? So that's a primary barrier. But we think that if we can really get everyone to think a little more broadly and realize that to spend a little bit more time, to use the data, to be intentional, that the sum of the parts is greater than each one of the individual sectors. And that's what we're trying to see. And we really are working across these sectors in ways that we never did before. I was saying yesterday, I don't know if you were in the room, Andrew, but at the foundation we've worked in teams. And in fact, we had two sides of the house. We worked in healthcare and health. So it was kind of clinical and prevention. But we've merged, under the culture of health, we've merged those two sectors. And although we still have some focus areas, but it really is about how you are working across the different areas. So I work in childhood obesity, and I work in this catalyzing demand, this new area, working with Federal Reserve banks, regional chapters, try to drive this, but it's very much to look across. Other questions?
Undergraduate University of Memphis, and I majored in anthropology. This is kind of the question I wanted to ask about focusing on the psychological needs and devices of the people who fall between cancer and Memphis. What steps could a person like me take to advocate that they might need to go and develop in my because I know like I see that this very structuralized conflict everything. Conflict, everything. Well, where does a person like me start as a working?
I think the first thing that we all have to do is to understand what the community values, what's important to the community. So as a young person, do you live here in Memphis? Or okay. So, your neighborhood, your community, other communities that you want to work with, maybe you're working with some youngsters somewhere, or maybe you're helping out at a senior residential facility, is to understand what they value, what their needs are, and what their vision is to see how life can be better, easier, more healthy for them. I think that's always the place to start. And then to bring in, to relate, the things that you'll hear today and from your own training in anthropology and at the university, that's where you start. Oh, here.
Following up on the question about barriers to collaboration, could you give some examples in the U.S. of communities that are doing a good job of cross-sector collaboration?
Well, I think the city of Louisville, Kentucky has done a pretty good job. They started back in the early 2000s looking at their city, looking at how they can make some improvements. They were, struggling economically, like a lot of places, right? And they started focusing again on the small things, walkability. In fact, I worked for a different organization at that time, and they brought us in. I worked for the National Center for Bicycling and Walking, and they brought us in to do some community visioning workshops. And just like I said to this young man over here, we didn't go in saying, I have the answer. Certainly, I've seen a lot of communities, what they do, and as a planner, I can talk about it. But what is it? What's going on in this neighborhood? What do you value? And go from there. And so they started with that as a sort of building block. And they also knew that they got the businesses involved. Humana has a huge presence in Louisville. So they brought Humana in, to listen, to help shape what was going to happen, to be an active participant. And they worked with other businesses too, not just the big giant Humana, but other businesses. So Louisville is an example. Chattanooga is an example in Tennessee. I talked a little bit about that last night with someone. Chattanooga in 1969, Walter Cronkite said on national news that it was the dirtiest city in the country. That changed. It changed because they knew they had to compete. They had to compete within Tennessee. They had to compete within the region. They had to compete within the nation. And they looked at one of their greatest assets was their outdoor environment. How do we improve that? How do we clean it up? How do we make this a city that people want to come to? How do we attract a good workforce so that other businesses will come? Those are important. Oklahoma City, same thing. The mayor there, knowing that they were losing their young people, that if they stayed home to get educated, they stayed in the state, they weren't coming back to Oklahoma City. So he put the city started focusing again on the physical environment. How do we make this city more attractive for young people? And again, they focused on walking and biking. I don't mean to say that walking and biking is going to, change the world, but it's those little things. It's part of those building blocks. How can we make those improvements? How can we relate to people where they are? So he did that. He put the city on a diet. He had a website out. He got everyone involved. So those are three examples. I think the mayor that was going to be here today, tip of my tongue, Chip Johnson from Herndon, Mississippi. Again, small city, right, nearby. And he focused on, one of his focus areas was how do we bring down the cost of health insurance for public employees. And that's where his starting point was. And that created cross-sector collaboration. Other questions? Comments, thoughts?
Sharon?
Yes.
I was wondering if you could talk about the foundation's listening sessions in the South, what you know about that yet, and why would they happen, all that.
Okay, thank you. So because, again, our work is still new in this area, we're just beginning, and we want to make an impact where we know the health disparities are the greatest, and that is in South and Appalachia. So we are, in the spring and into early summer, we are conducting listening tours in 7 states in South and Appalachia. In Tennessee, I think we're going to Nashville. We were going to Chattanooga, but I think we're going to Nashville. So we're going to be coming in to listen, to hear what you value, what your concerns are, and how you think change can happen. Because we're at the foundation, we're not going to just sort of parachute in anywhere and put our values on you and what we think you should do based on, we do a lot of research, evidence building, but none of that's going to work. We don't understand what's happening here and how change happens. So we have these listening sessions. They're day-long sessions. But what I have begun to promote with my colleagues too is to come to meetings like this, where you're already meeting, where it's happening, and to hear from there. So, and I'm going to take back my what I hear today and bring that to the foundation, and that's going to inform us in the work we do going forward, how we can help. Other questions?
In our lifetime, we've kind of seen the death of small farms, and as part of that, it's made also produce go up. And a large part of health is your diet. And so we see that low-income areas, it's hard for them to get good produce and also afford it, and it's cheaper to get little veggies. What kind of, I guess, what's out there to help change that and help get, and are there any initiatives out there to help get better food produce to lower income?
Yeah, that's certainly a big concern. I know that you have, through your Community Development Corporation, you have a food store coming into the to an area that's a food desert. So, and hopefully they'll have fresh produce and all that. And I know maybe I'll ask Andrew to talk about the farms, the farms that you have at the community farming that you have going on at Shelby Farms. So, it's measures. Go ahead. Do you want to say a few words about that?
Oh, well, I think there's a lot of local gardening and local farming going on. I do think it's a challenge to get that into stores, the fresh produce into the stores. But we just, through the Memphis Reach Project, the YMCA developed the Healthy Convenience Store Initiative. And that's a model that CDC's can use to encourage neighborhood-based stores to improve their access and selection of local produce. So I think that in the area of locally produced fruits and vegetables, as well as improving access, we're really working strong in those areas throughout the community at a variety of levels.
Yeah. What I've seen across the country is really a concern about the same thing that you're asking. What do we do to get fresh fruit, food, and produce into neighborhoods where it hasn't been? We have supported programs called corner store initiatives to help bring again, healthy food into neighborhoods where there isn't a supermarket, a grocery store. So we've taken those initiatives. We've worked with the large community development corporations and CDFIs to help bring the financing to make that happen. Hopefully we'll start to see more of that happening in Memphis. But there are initiatives. There's a greater awareness and emphasis on locally grown food and what can happen to bring that here. And hopefully you'll see more of it.
One of the things that the health department is doing here through our health information division is having employees have a place to have a community garden within the structure within the courtyard of the health department. And that's
Wow.
a new initiative that will improve things for our employees, but more than that, they're going to go back and resell it to their friends and neighbors as they continue to the garden hall, during the break.
Wow.
So
That's great. That's really great. And, by observation, you all tell me the truth, but Memphis is a low-density city, and your transportation, you don't have the train, you depend on buses and cars. And for people that may not be able to afford the bus or have their own car, it's really important to have that food as local as it can be, to be accessible and to be affordable. Otherwise, you're going to buy what's right there. So it couldn't be more important. So examples like that. Are there other examples that anyone in this room wants to point to? Yeah.
Well, I wonder how much availability of healthy alternatives, like I said, it's a real problem. It seems to me that we've got some real serious problems like infant mortality, childhood obesity, and just obesity in general, and strokes in this particular community. And it seems like, and I'm guilty of it myself, it seems like education and behavioral change is what's really key. And it's just really hard to change people's behavior or choices instead of McDonald's, eat a salad or something. That seems like it's been a problem, infant mortality is a problem here for a long time.
Right.
That's right.
Right. Well, and I know that's almost a default position. We think we can educate, we can get people to make better choices, and certainly that's a piece of it. But when there aren't good choices to be made, when there aren't those opportunities, we can educate, till the cows come home, and the opportunities have to be there. Infant mortality, certainly that's a huge problem. But what about maternal health? To make sure, again, that the healthy food is there for the moms, that they can get to it, and areas to be safe to have physical activity. That too, in terms of maternal health, stroke, diabetes prevention, those, we really at the foundation, this culture of health is about making sure that the physical, the social environment supports, making the healthy choice the easy choice. For so many people, it's just not there. Yes?
In Memphis, we have a thing called the Green Machine, and it's been about a 7-year collaborative that has evolved, and a Nevada bus was given and refitted, and it now carries fresh produce.
Wow. The grain machine, for anyone over here that hasn't heard of it. Okay, go ahead.
And the nursing students at the University of Memphis also go on it as part of their community project. And they bring recipes and do tastings on there 1 day a week. And we originally thought it was only going to have 5 stops, and it now has 20 stops, and it makes in different food desert areas in Memphis.
Wow. That makes a difference. It's, again, bringing out. So you have a community nursing program, and the students get out in the community?
We put them out.
That's great. Okay, over Yvonne. Am I out of time?
I would mention
1 minute.
Okay, particularly with the Green Machine and other three initiatives that have been mentioned, they do really represent strong levels of collaboration across the community and multi-sectoral collaborations. The Green Machine was a product of a local food community that was folks interested in producing local food and supporting that endeavor, coming together, working with the private foundation, working with the health department, working with the university. It's got a lot of players involved, and it takes all that to sustain it. So we do have successes that we can build upon. It is a matter of really highlighting those. There is another very strong collaboration around healthy eating, active living that is ongoing, and that's the Exchange Coalition. It really is committed to looking at how do we reduce obesity and create opportunities for healthy living and active living. With multiple players involved in it, each of us looking at those issues from our various domains, where we eat, where we pay, where we live, where we pray, etc. I think we named or about 6 of them. Coming together, not quite fully a collective impact model, but very close to that in terms of identifying common mission, common goal, and then everybody owning that common mission goal. Not 100% overlapping all the time, but and it sustains itself over the last 5-7 years. So again, it's those kinds of products that are the output of that.
We do have examples here.
Yes. Do I have time for one more? Okay.
Again, I'm a big fan of Memphis, but there's some real structural barriers here. There's when you put them together, I think we put some unique barriers that we face. No state income tax, the city county government, the history of segregation, the deep levels of poverty, the workforce, professional workforce, all lives out in the suburbs. They commute in, so you don't have that vested interest in many of the neighborhoods. Those are things that, to bring people together, it really creates challenges. And not that it's all unique, but I think when you put them all together, it really is a very daunting task to try to address some of these changes. And just any thoughts about, any of the uniqueness perhaps that I sort of see here in Memphis versus other cities.
Yeah, well, but all that, yes. And every city and every place has its challenges. Certainly, I know that poverty is a problem in Memphis, and it doesn't take much to ride around and you can see it, walk around, and you can see it, right? But there's so much opportunity here too. I mentioned during my slides the area around the airport, 50 square miles. That's a sort of something big. And the federal government is investing in that. You have a grant from HUD. It's not going to pay for everything, but it's the start. It's the seeds of something. From there, you can grow out. What's happening downtown? Clearly, that's to keep people in the city. Maybe for many years, people were leaving because they didn't see a future for themselves in the city. You told me last night you live downtown. You see a future for yourself here, right? So when we do that, when we look at the jobs that are coming in, workforce development is health. a building like this, the University of Memphis, putting its law school downtown, is saying, we're here to stay, we're going to work with the community, we're going to help, fix Memphis, if you will, and be a house of the people. That's where it becomes. Money is spent here every day. I can open up as someone who ran the capital program for the fourth largest metropolitan planning organization. I can tell you, open that up and look at how much money is spent in this city and this region on transportation. If you factored in the right priorities, the right metrics, you can get the right kind of community development. And they're doing it in Nashville. The Nashville MPO has built health into their criteria for selecting projects. So it could happen. When people say we don't have the money, money is being spent every single day. It's what are your priorities? What are the criteria? What is the public participation process? I think I'm out of time, right? Well, thank you so
We'll reconvene promptly at 10:30. So if you, we have coffee, we've got refill of coffee and some snacks outside. Their men's bathroom is this way. If you're like me, this is important information. Women's bathroom is this way. Just to let you know, we have some copies. We're going to get more after the lunch break. The printer needed a rest, apparently after a few. But we have copies of an article that Maris Ash was kind enough to share that's really brief and kind of a look at sort of the themes that we're talking about. They'll be over here. If you don't get a copy, I promise more coming after lunch. And briefly, because this is the start of a conversation, also over here, as well as outside in the little lobby area where there are the seats right near where you eat, I'll also put a copy there. If you want to put down your name, contact information, and what you want to bring to the table, and what you want to get from the table, so we can continue the conversation, that would be great. And I promise to keep my emails to you to a minimum. Sort of. All right, thanks, everyone. Yeah, and I'll make sure that all the attendees as well as everyone. I know, I was about to say, really? I know, I was just like, I need to reference
Are you the IT guy? No, you look just like her.
Just gonna say the.
Presenter, Oh, wait, there it is. There it is. No, wait, here, wait, here. Try that one, that one, this one, yeah.
Sorry, this is a new setup? Yeah, it's brand new. Hey, how are you?
We can tell them.
I think we're going to get started. If folks could grab a seat. I want to thank you for hanging with us. Lunch is coming, I promise. First, I want to introduce who's going to be introducing our panel. Maureen O'Connor is the Vice President now for Institutional Advancement at Le Bonheur Children's Hospital, part of the Methodist Le Bonheur Health System. Maureen O'Connor's background is in addition to being in news reporting, she also before this was the head of government relations before the promotion. And I just have, she's one of my favorite people. In addition, I see Kathy and Christina back there with Le Bonheur and the CHAMP program you'll get to meet later. Le Bonheur has been a wonderful partner for us. You heard a little bit before about our about to launch medical legal partnership. The way that they've come to the table and as a healthcare community said, we actually could see some value in lawyers and we get how you could help and how we could work together. That doesn't always happen, but Maureen has really been a champion and is so kind to come and take time from, I know, a busy schedule to introduce our panel today. So.
Thank you, Amy. And one of the most important things I need to add to that is that this has been a tremendous team effort in terms of putting together our medical legal partnership, and we're just really excited that we're almost there at this point. So next time we have an event like this, we'll have the opportunity to really tell you how we've been moving forward and how we've been able to help children and families. Well, the first thing I'd like to do is thank Dean Letsu and Amy for inviting Le Bonheur Children's Hospital to be part of today's event. This is just another step in our wonderful partnership, and we are so pleased to be working with the law school as well as Memphis Area Legal Services. The goal of our partnership is to improve the health outcomes of low-income children and their families by using law to advance health and well-being. Through our medical legal partnership, we will also be able to offer education, engage in advocacy around child and family health, and build a base around the value of public interventions, all in the interests of betterment for our community's health. It is an honor to really join you today on behalf of the Bonner Children's and bring a children's hospital voice to this event. It's my pleasure now to introduce to you our next two speakers, Maris Ash and Elizabeth Tobin Tyler. For 36 years, Maris Ash, CEO and founder of Oakland-based Change Lab Solutions, has advocated for public health and creating communities where the healthiest choice is the easiest and the best choice. Change Lab Solutions uses the tools of law, public policy, and community engagement to help all communities improve their health, especially those that are at most risk. They work with leaders in every state of the nation and through every stage of life to create practical and lasting solutions designed to empower people and save money. Maris is a graduate of the University of Notre Dame and received her MPH and JD from the University of California at Berkeley. Our second speaker is Liz Tobin Tyler, and she is a clinical assistant professor of family medicine at the Alfred Medical School of Brown University and of health services policy and practice at the Brown University School of Public Health. She is also co-director of the Scholarly Concentration and Advocacy at the Alfred Medical School. Her work focuses on the intersection of health disparities, social determinants of health, law, and policy. She is a leading expert on the development and promotion of medical legal partnerships, which address the unmet legal needs of vulnerable patients and populations in order to improve health. Please join me in giving Maris and Liz a very warm Memphis welcome.
Thank you. Like Sharon, I'm really pleased to be here. I don't have history with Memphis. I think when in college, I went from South Bend, Indiana to Fort Lauderdale one spring break and spent the night in Memphis, and that was the last time I was here. Close to 40 years ago, which is kind of shocking, but true. I'm learning. I had a great tour yesterday and learned a lot about Memphis, and I'm learning more, and I'm thrilled to be here. I learned from Sharon just today, so that was great. I'm going to introduce briefly Change Lab Solutions. We're a nonprofit organization. We're based in Oakland, California, but we work nationally. We've worked in all 50 states, in urban centers, suburban, rural communities, more and more, in fact, in rural communities because they have different needs. We've been kind of told we're too urban-centric, so this urban rural differences are very real. We use the tools of law and policy, and I want to dig in a little bit. We're in a law school, and some people say, law school and health, how could that be? In fact, on the UC Berkeley campus, if anybody's familiar with it, the only school that's further away, the School of Public Health is in one corner. The city planning school is about as far away as you can get from the School of Public Health, except the law school, which is right next to the city planning school. You think they don't even belong to each other, when in fact they're so intricately connected. My own history is I started as a health educator. I'm trained as a health educator. The question we had earlier, well, why can't we educate people? I'm going to dig right into that because I believe in educating people. It's my first profession, and that's what I'm most committed to. But I reached a limit on what I could do as a health educator, and I talk about the finger-wagging style of health education. You really should quit smoking. You really should eat better and exercise more. That style of health education is long gone. It doesn't work. It doesn't mean that we don't need to educate. We absolutely do need to educate. But if we want to change health outcomes in a big way and start moving the needle on what matters to our communities, to our families, to our budgets, national and local, then we can't rely on education alone. It will be a failure. So let's dig in. We at Change Lab Solutions, we develop tools that communities can use to actually change the environments. So these are just examples of what we call the social determinants of health. What is it in our environment that determines health outcomes? Our transportation system, our housing, whether or not we have active living, Are our schools focused on health? And I will say that Tennessee is regarded as one of the best states in the nation for comprehensive school health. Now, it may have a long way to go, because I'm not saying that the nation is in good shape as far as school health issues, but Tennessee has made more of a commitment than any other state in the nation. Do we have access to healthy eating? The question, that access question that was asked earlier today. And is there economic opportunity, both for entrepreneurism and for job creation and job growth? These are, and there's more, we could put other things up there too, but these are what happens in our community, how we have our community structured that actually impact health. We've talked about this a little, and Jim Marks, the Robert Wood Johnson Foundation, is Sharon's boss's boss, I think. Tell me your zip code and I'll tell you how long you live. This is Memphis. This just came down, this diversitydatakids.org, just last week. And it shows that the opportunity categories, I bet, I don't know Memphis well. Yeah. Uh-huh. No, I don't. Maybe we do need the IT guy.
I thought that was all part of her long wind-up.
No. I'm
like, wow, this is in-depth.
See, that's why I couldn't get that to work. Technical moment, please. Let's go back to how it was, and I'll just make it work. Okay, now can we advance it? No. All right. We do need the IT guy.
Yep, I just texted him.
Okay. All right, so.
Right now, you can use, this.
No, it's not working. Oh, okay. Oh, so it's this? Whatever I was using was, okay. All right. So let me just. All right, so it's not changing for me, but it's changing for you. Okay. So excuse me if I look over my shoulder so I know what I'm looking at. These were the social determinants of health, okay? Transportation, housing, I won't repeat it, you heard what I said. Zip code, okay, map of Memphis. So what you'll see, this just came out last week, and it's a great website because you can go on it. This is the Memphis metropolitan area. You can go to any city in the country, and it's all about how well children do. And we know the 0 to 5 is the most critical time of life for kids. And you will see, and I bet, without knowing Memphis, I bet that these, you can see where the dark is, that we could track anything. How well it's going to be linked to income. My guess is this is linked to income almost directly. Thank you. We could put at the transportation system, and you'll see the exact same pattern. We could put, I'm guessing this, but you guys can tell me, we could put where the job opportunities are, where the education level is of the community. We could put almost any of those variables where the housing is healthy and where it's unhealthy. We could put almost any of those variables on this map and it would look virtually identical. These are the social determinants of health. And you put the health outcomes on this map for this population, it will look identical. Over and over and over again, we'll track what's the health of the community by income and by the social determinants of health, how we structure our communities. I can make this work. If you can't, I'll just work around. Oh, no, nothing's working. Okay, good. Yeah, I don't know why either. Okay. One of our challenges as a nation is we think about health as health care, and Sharon talked about how great we live once we're 95 years old, pouring so much money into the last years of life. In fact, one more down, there we go. When we look at medical services, okay, thank you. We spend 96% of our federal budget on medical care delivery and 4% on prevention. When we look at the causes, the factors influencing health, it's our health behaviors and the environmental factors. You're not going to walk a lot if you don't have a safe place to walk. You're not going to buy healthy foods if they're not affordable and not available in your neighborhood. Those health behaviors, those social norms that drive health and the environment that shape that health account for, here it says 70, I've seen 80% more of what causes health problems, and we spend 4% of our healthcare budget on it. What if we were to spend some of our transportation dollars, some of our housing dollars, just as Sharon said, with a specific focus on what is a health outcome for the use of these dollars? What this slide shows is that if we think the health department alone is going to solve the problem, we are wrong, flat out wrong. They don't have the money. They have less money probably than everybody else if they're a typical health department. They don't have the know-how. They are not transportation experts. They are not land use experts. They are not housing experts. And they don't have the legal authority. Even if they had the expertise, the legal authority resides in other places in the community. They have to work in partnership with those experts, those holders of the fiscal purse that could have the authority to put money one place or another. If we're going to be successful in addressing health, it will not be done by the health department. They are a partner and a partner only. They need every other sector of the community. Yay, change for me and for you. This is another way of looking. Tom Frieden's the director of the Centers for Disease Control. CDC. In my world, it's the Centers for Disease Control because I come primarily out of public health. In the world of community development, CDCs are community development corporations. In the state of California, where I come from, if you're in crime prevention and juvenile justice, it's the California Department of Corrections. Just getting our basic, what flows out of our mouth, what we think everybody understands. In fact, we don't all understand, so all the reason why we have to talk with each other. But this is the CDC from the Centers for Disease Control. Education is here. This is increasing the individual efforts and increasing the population impact. We have education. It's important. It's absolutely important. But if we want to have the biggest impact on health, we have to work at the bottom of this pyramid, the socioeconomic factors. Those are what predominantly influence health outcomes. And changing the context, and I'm saying that changing the context are the laws and policies that create the socioeconomic factors in our communities. Changing the context that make the individual choices easier. If you only have fast food, what are people going to eat? Or it's predominantly, and it's on the TV, and it's on the sports, and it's on everything else. That's what people are going to eat. So our goal as a community is to work as low down on this pyramid as we possibly can. And the lower down we work, the greater impact we will have on community health outcomes. Now this might still be seen, we're in the hotel down the street, and we came over here for the reception last night, and we could smell all the smoke, and I assume it was in the bar. So maybe there's some bars still left in Memphis where smoking. But I used to be a smoker. I was a pack-a-day smoker when I was young, and I would smoke, going out and have a drink and smoke, and it was a lot of fun and whatever. This was commonplace. We talked about the changes that have been made. This was the norm. Let's take a look at this kind of bell curve. This is smoking tobacco use rates in our country. And what happened in World War II? There was a public policy in World War II that drove tobacco addiction. What was it? Right, free cigarettes in the mess kits for the GIs. Now, who thinks that the Department of Defense was trying to kill off a generation of GIs? No, they weren't. They didn't mean to actually cause long-term harm to their warriors and to our heroes. No, quite the opposite. They were trying to give them succor and comfort and something, a little bit of a treat. But the GIs came back addicted. Their wives and girlfriends became addicted. My father was 15 when the war was over. His heroes were addicted. He died of lung cancer 7 years ago. My mother was a smoker. 4 kids in my family, we were all smokers. Very typical pattern. That was a public policy and unintended consequences that drove disease rates and was the leading cause of death and still is in this country. What changed it was the non-smokers' rights movements, tobacco control, smoke-free workplaces, smoke-free public places, and cigarette taxes, public policy. It was the use of public policy with an intended outcome of driving down disease rates that has overwhelmingly changed the face of health in this country. Who's still smoking in this country? Does anybody know who's still smoking? By and large, who's still smoking?
Those with mental illness.
Those with mental illness and poverty, and the poor and the mentally ill. That's exactly right. That's who's smoking in this country. And we did a study in our shop in California of we have pretty good comprehensive tobacco control laws in California. In fact, they're so comprehensive that over the last 20 years of our program, we have saved 134 billion with a B medical care costs in California alone. Who's still smoking? You go into our smoke-free workplace law and you look at it through the lens of equity. We have exemptions. Most places you can't smoke. You can't smoke in some communities in outdoor dining. You sit outside in the cafe, no smoking, because there's, who wants it? Blech. But you can smoke in long-term care facilities. You can smoke in a lot of hotels. You can smoke inside of cabs of trucks. You can smoke in warehouses of a certain size. All those workers, predominantly low-income workers, predominantly workers of color. Who is left because of our public policy? Now, when we passed that smoke-free workplace law 20-something years ago, nobody did that equity analysis of how our exemptions are actually impacting low-income communities and communities of color, and that is who's smoking. That's who's being exposed to tobacco-related diseases. That's where we see the highest incidence rates. That's where we see the asthma in the children. And it can't be surprising. We have got to be intentional. So we're going back. We just did this study last year. I said, let's look at an equity lens. We're like, oh, my God. And now communities all over California are saying, this is not acceptable to us, and we're changing. We're closing those loopholes. We are trying to be intentional about what we're doing, particularly where we see the evidence of disease. I say this is the exact picture of the smoky bar scene. We see this in so many communities. I say this is the exact picture of the smoking bar scene. How we design our transportation systems leads to disease. This leads to stress. This leads to air pollution. Probably this freeway was cut right through the middle of a low-income community in the 1950s. I bet, because that's what happened in most communities. You want easy on and off. The land was cheaper. Split it right through the community, upset the community life and structures. I could go on. I could put up pictures of almost anything. Abandoned lots, garbage not picked up, playgrounds that are locked and closed, no safe places to play, parks that have hypodermic needles and condoms left in them rather than green grass that's mowed and maintained. Over and over and over again. These are social determinants of health, and we can't be surprised that when communities are inundated over and over again, that we have bad health outcomes. And it won't be, you better eat healthier and stop smoking. This will not do the trick. It is, I'm a health educator, it's shown to fail. So we have these social determinants of health, and what I'm going to talk about is how do we put health policy so we have intended consequences to drive to exactly what we want to get out of our community health. We do that very consciously. And that's the challenge to Memphis. And it's not just Memphis. This is the challenge to the whole nation. So what do we mean by this? Health in all policies is a collaborative approach to improving the health of all people by incorporating health considerations into decision-making across sectors and across policy areas. I hope I made the case for our land use, transportation, housing policies that is absolutely essential if we want to change the trajectory of community health. Our goal is good governance for healthy communities. It takes governmental leadership for this to happen. It doesn't happen by good intention alone. It takes leadership, it takes direction, it takes purpose. I'm going to quickly go through 5 steps. We're writing a toolkit on this. I'll just say everything that I'm going to be talking about, all this housing, parks, fast food, all of this. We have tools on our website. I'll give you the web address at the end that are just download and use. toolkits, model ordinances, the whole fact sheets, FAQs, everything you need is available for you thanks to the Robert Wood Johnson Foundation, thanks to the Centers for Disease Control of the state of California, and much more. Okay, 5 steps. Herding cats, getting all the cats not only going in the same direction, but playing well and sitting down and being polite with each other at the same little tea party, right? This is hard to do. This might be the hardest part of everything I'm about to tell you, is actually getting people aligned and being able to learn from each other, understand what CDC means in your world, and there's many. What is health equity? What does the word equity mean? In a health context, we're talking about racial justice, we're talking about closing these gaps and disparities. In the Community Development Corporation world, equity has this whole thing about, you know, how much money you're going to make at the end and what's the value of something. We don't even, I mean, really, our basic language isn't even aligned. We got to get there. There are right from the federal government, National Prevention Strategy, part of the Affordable Care Act, 19 federal agencies talking together to figure out how we're going to prevent disease by working together. So it's happening right at the federal level. The Surgeon General's office is coordinating it. Here in California, where I live, here are all the different organizations that are working together. And this was Governor Schwarzenegger, and a Republican governor in our state, started this, and Governor Brown is keeping it up. But you'll see education, housing, the forestry and fire protection. I mean, we're talking the whole gamut here. Nobody's left off the hook. Here's the goal. California's decision makers are informed about health consequences of various policy options during the policy development process. We can be intentional about how we affect health if we are informed and are having the conversations that need to be had. Seattle, King County, a learning team from all agencies in King County government that passionately engages employees and community residents and leverages activities that create equitable opportunities for all. They've built health equity right into their city government. City of Vancouver, too big to see everything. This is British Columbia, and I had a little video which I learned that I didn't have the technology to work, so I didn't even try, but there's a whole, if you go on their website, but you'll see they've got all of city government engaged in health as the center of what they're trying to achieve together. So how do you do it? Building block number 2 is you engage and envision, and this is deep work. You know, we talk about grassroots and treetops. Treetops being, you know, the big fancy people in town, the grassroots being the everyday folks in the neighborhoods. You gotta be working at all levels. But you've got to engage and envision. I'm going to show you a few slides of what it's looked like around the country. Kids being involved. Imagine what would you like in your neighborhood? What would it be great if you could have a safe place to play? And what would you want that play structure to look like? Here's a group of teenagers who are given all sorts of stuff to work with. And they developed what they want their community to look like in 50 years. This is youth development. This is the children of the future are going to be the leaders of this community saying when they're teenagers or younger, this is what I want. Harnessing that aspiration, getting those kids to have a voice in what kinds of policies Memphis are developing. This is your leadership of the future, and this is the hope. These kids aren't jaded yet. Get them while they're not jaded, and harness that energy and give that energy some forward action. Make a plan. We don't know where we're going. We're never going to get there. There's got to be a plan for it. Here's a small town. This is not big city stuff. You can see that they got their kids involved in this, and they have a community health element to their general plan that use the children. I mean, I'm not talking teenagers. I'm talking little kids here all the way up to help design what that community future wants to be. Talk about keeping your kids in town. You get them involved early on, and they see that change, and they have ownership in this community. They'll want to stay because it belongs to them. This is a town, Richmond, California, very low-income community, big petrochemical facilities, all sorts of problems, as many problems as Memphis has, and maybe even more on top of it. Not as big as Memphis, not as many resources, although they did pull in private, the California Endowment funded this effort. They worked on community health and wellness in their general plan. Health policy was critical. This is who they involved: government and leadership, economic development, Safe communities, all the residential and built environments, all, you see, the whole thing was baked into their general plan. And look at this, if you can read it. Who's got the lead responsibility? I don't know if I can use that. Planning and building services, engineering, public works, redevelopment agency. This is just one. Planning and building services, maybe I said that. You don't see the health department. What are they looking on? Safe routes to school, traffic calming, lower speed limits, streetscapes improvement. This is all about public transit. Just one section. It's not the health department. It's all the other departments in the city saying we are going to work together to improve the health, lower injury rates, make it safer for our kids to get to school. It's not the health department's challenge, although they probably said, here's where our data shows that people are being harmed and what we're dying of or being injured by. This isn't going to happen if there isn't money on the table. And I think I'm going to be a little bit more pointed than Sharon was maybe and said, there's plenty of money here. It's how you're using the money. You can't say that we don't have enough money. It's being intention on how we are using that money and having a plan and investing in the plan. So we've talked about this guy from Hernando, Mississippi. This is Chip Johnson. Small town, Republican mayor, Deep South. He hasn't gone to college. He says he went to Maritime Academy. I've had him at a number of workshops, and we're lawyers and all these policy wonks. He said, you know, I graduated from high school and went to Maritime School and was a merchant marine, and now he moved back home and he's the mayor. So you don't have to be, fancy law school or anybody else with your letters after your name. You need to be somebody who really cares about a community and gets it. A healthy community is not just feel good, it impacts the economic development. He looked outside of his office and there was no sidewalk and people were like trying to get to work. Nobody could bike or walk to work because they couldn't get there. We save 15% off our insurance costs. Taxpayers, this is a small town, $130,000. That got reinvested into employee wellness programs. But when you look at some of the improvements that you want to make, there's dollar factors there too. So you invest to reap benefits. So per 1 million spent on transportation costs, look at this. For just the road only, you get $7.8 back. For cycling projects, 11.4, because you start building in economic development when you're doing these community improvement strategies. And in almost all of these, you'll show the cost savings over and over again. Healthy housing, asthma admissions into the hospital, overuse of ERs, costs of that go up. You could invest that in healthy housing from the outset and save tremendous amounts of money. Okay. And it stopped. Okay, tracking progress. Here's the city of Richmond. Again, look at this, governance and leadership and implementing. They've got the health plan, the measures. What are they going to measure? How are they going to know if they're going to do it? They have health equity built right in. How are we going to take all children deserve access to safe places to play? But we know that the parks really aren't good in X neighborhood. You fill that in because you know Memphis. And that's where we're going to start. We plan, part of our plan is the health equity agenda that gets baked in from the start, and we measure ourselves against it. The city leadership on tracking progress towards health equity, utilizing existing city and county state data. Your health department can give you the data on how we're doing. The Parks Department has to implement the programs. We could talk about health in all policies. We could talk about kids in all policies. We could talk about education in all policies. We could talk about equity in all policies. Economic development. Fill in the blank. What do you want to put in? This young man asked, where should I start? Good question. My answer to you is, where's your heart? Where's your passion? Where do you want to start? If you think about things in a systems perspective, it doesn't matter where you start. You can start anywhere and you're going to start affecting the whole system, one way or the other. You could start with community gardens. Really easy to do. But how do you get access to the land? How do you get water there? Are you allowed to sell the produce in an off-site venue? These are all legal questions. If you go on our website, this is Law and Policy, you can get some answers. And you'll have to bring in Tennessee law, but we'll show you how to find out what Tennessee law is. And you can start building your policies to affect the kinds of change you want. Are community gardens going to solve childhood obesity? Nope. Are they a place to start, and communities start owning the land in their neighborhoods, working that land, getting their hands dirty, seeing fruits and vegetables actually grow? This could be a radicalizing experience in some neighborhoods. Doesn't matter where you start. Ultimately, we need a lot more than community gardens. But if that's where people want to start, that's a great place, and then you move from there. So I will end. Lots and lots. Here's Dig, Eat, and Be Healthy. Growing food on public property. There's just one of dozens. I have a publications guide. And there's our URL, Change Lab Solutions. Please use the resources however you can. And I thank you for letting me be here. I'm going to pass the baton, or this, whatever it is, clicker to Liz. Oh yeah, and the mic too.
See if it works. You know, I joked that yesterday. I said I finally figured out the technology, and lo and behold, they changed the darn computer system on me. I can't. It's too bad. I'm too old for this. I'm too old. I want to talk for you. I can do that.
What do I need to do? How do we get the screen?
We can see it now. We can see it here.
It's here.
Oops, sorry.
Thank you. Yeah, I have taken to asking my students to be my tech support because they're much younger than I am and they can figure these things out. It's such an honor to be here. It is actually my first trip to Memphis, and we had really just a wonderful southern welcome since we've gotten here yesterday, but also a tour around the city, which was really, really helpful for me as someone who's never visited here before. To really get a feel for both the issues and problems that you face, but also some of the real opportunities. So it's really terrific to be here. It's also fun for me to be in a law school. I taught in a law school for 10 years and now teach medical students and public health students. So it's fun to have interactions with the law students and be back in a law school classroom. I'd love to just do a quick poll of the audience. I'm going to talk more about the integration of healthcare law and public health. And so I'm curious about how many people in the room are healthcare providers or students. How about law students and lawyers? Okay, great. And then people who work specifically in public health? Great. So what a great mixed audience. That's terrific. I think it'll be interesting for you to think about how we can work together better. And I'm hoping this little guy is going to work for me. We'll see. It did. Good. So what I'm going to talk about specifically is medical legal partnership. And I'm thrilled to hear from Professor Campbell and others that you're working on developing one here. And I'm going to talk specifically about how medical legal partnerships can really help to break down the silos that we have all been talking about, particularly among healthcare, public health, and legal aid. And also how medical legal partnerships can help sort of what I call connect the clinic to the community by really detecting and addressing community level health threats and doing that through a partnership of multiple providers, but also through legal advocacy and representation. And also how medical legal partnership can really help to begin to identify systems problems and particularly issues around enforcement. And we'll talk about how a lot of this is structuring our laws and policies appropriately. But when you get down to the ground level for families on a daily basis, often it has to do with enforcement of existing policies, right? And particularly for vulnerable populations who may not have access to advocates who can help enforce existing policies or laws. And then finally, if there's time, I'll talk a little bit about a couple of other sort of clinical and community partnerships around healthy housing that I've been involved with. So one thing I wanted to talk about with regard to healthcare, and we're talking a lot about social determinants of health and sort of the distinction between focusing on health versus healthcare, right? It's not just about access to medical services. On the other hand, with healthcare reform, there's an enormous amount of recognition within the healthcare community that we need to be thinking about what happens outside of the exam room. And providers, people who are providing healthcare services on a daily basis, they're seeing the results of our failed policies and systems every day. Dr. Megan Sandell, who is one of my colleagues at the National Center for Medical Legal Partnership, she's a pediatrician at Boston Medical Center, and she likes to say, you know, we as doctors see on the bodies of our patients our failed systems and policies every day. So there's a community in healthcare that is, you know, primed to help think about what happens in that community that where their patients come from and live. And some of the ways that this is happening through the Affordable Care Act is hospitals now are required to collect information about the communities they serve through community health needs assessments. And the law requires that they do this not just by, you know, talking to themselves, but, you know, engaging people from the community, stakeholders in the community, patient representatives, people, you know, who can really try to drill down into what are the problems in your community and how do you think they're affecting your health? What do you think the health issues are in your community? So it's an opportunity to get the healthcare sector to be thinking about these issues. Community health centers, which serve very vulnerable patients, are being widely expanded under the Affordable Care Act. And they are really interested in, and have done for a long time, but really interested in these kind of broader systemic issues because they know if their patients don't have transportation to get to the clinic, they're not going to be able to serve them. So working with them. I just was talking to folks at academic health centers, the Association of Academic Health Centers. They have a new initiative called Social Determinants of Health Forward. You know, how can we begin to address social determinants through health, a much more thoughtful process for healthcare providers. And then there's a real emphasis on health professions being trained interprofessionally. And one of the ways that I think we need to expand upon that is to have lawyers in the mix. How are lawyers partners in thinking about addressing the social determinants of health, providing higher quality care? So I think Mara said, you know, what does the law have to do with it kind of question when we think about health. We know that the most common legal problems that people have, particularly very low-income populations, have a direct result on their health. They are social determinants of health. We know poverty is a huge social determinant of health. But oftentimes there are legal barriers that are standing in the way of people being able to access the resources they may be entitled to. So, you know, being wrongfully denied particular public benefits, certainly housing code issues, a child living in housing that has mold and rodents in violation of housing laws, access to appropriate services or insurance. So these are we know the connection exists there. But our traditional approach to legal aid or to lawyers providing services to low-income families around many of these issues is through, you know, legal aid organizations. You can see here, if you're low income, good luck finding an attorney to help you out, right? The private sector, we've got lots of attorneys for people. But in legal aid, there's one legal aid attorney for 64,000 people. And these programs are extremely overwhelmed. So, you know, we like to talk about there's just not enough legal aid in the pharmacy to be able to help families address many of these systemic barriers that they face and to be, you know, thinking about health as part of that. So I'm going to talk about you know, how does this connect to health, but also just note, you know, about 20% of the need for families out there who need legal assistance get it. So what does medical legal partnership try to do about that? Medical legal partnership is built on the idea of integrating lawyers as part of the healthcare team to identify, treat, and prevent health-harming legal needs of patients, clinics, and populations. So typically, if you're a low-income person and you have a legal problem, what do? where do you go? So you go to legal services. What do you have to do before you do that? What do you have to know?
Where it is.
You have to know where it is.
That it is.
That it is. You also have to know that you have a legal problem.
Well, that's true.
Right? So typically legal aid, and this is not to diminish what legal aid does, but typically legal aid is for people who have the wherewithal, to know where legal aid is, but also to have been able to identify that the problem they're suffering from has a legal component to it or a legal issue. Now that may be an eviction notice, but what's the problem with waiting until you have an eviction notice to get legal assistance?
It's too late to get it checked.
You
can't negotiate it.
Right. So it's a crisis-driven system. So the idea of embedding lawyers, and we've been talking about baking things in a lot, I like that term, baking lawyers into the healthcare team, is that they're on site and where to, what's one of the places that we know most people go, and granted there are plenty of people who do not have access to good health care, but many people visit their doctor or their health center, right? They go there, and often they have a good trusting relationship with that provider. So we're going to capture people in a different way if they're coming in to get to get medical services, health care. So what happens with a medical legal partnership, and how do we think about it as prevention, or what I like to call preventive law? We've talked quite a bit about asthma. A child comes to the emergency department with an asthma attack. Often severe asthma attack, they may stay in the ED or they may actually be hospitalized. What's the typical response of the physician? Medication, treatment, we're going to send you back home. But what if the parents tell the social worker, if there's a social worker, about conditions in the apartment? Or even better, what if we've trained that ED provider to ask about conditions in the home? Then we know that we might have a potential for an intervention. So in this case, if the social worker recognizes this and has also been trained that there is a housing code that should protect against certain housing conditions, then that social worker can refer that family to the lawyer who's on site or who's available. The lawyer can intervene with the landlord, take legal action against the landlord, and ideally that creates a better home environment for the child, improves the conditions of the home, and we don't see that child in the ER again, or at least not nearly as frequently. So that's the idea. So the other thing about medical legal partnership is that, and this is where I think it's distinguishable from traditional legal aid, is that that family that we talked about, or that individual that we talked about who identifies they have a legal problem and goes for legal aid, medical legal partnership doesn't view it as a legal problem, right? We start with health as the fundamental question for the family. And we know, these are all, if you look back to what Maris, other slides that Maris presented, what are the things that affect people's health? It's their income, it's their housing, it's their employment. For many people, it's their legal status. It's their family stability, which may include things like violence in their home. All of these things have legal components to them, or ways that we may address them through legal assistance. And we look at the whole picture with medical legal partnership. We don't wait for the eviction notice to have the client show up with their needs. So part of this is really to try to think about how do we break down the silos that we have created for ourselves very nicely, which is the healthcare system addressing the medical needs, public health trying to be out in the community or thinking more broadly about tracking disease at the population level, and legal aid, which is about enforcing people's rights and really promoting justice. So we've talked a lot about having the shared goal. And the idea here is that you're bringing together these different providers, legal partners, healthcare providers, to begin to capitalize on what they bring into this, together with the shared goal. And the shared goal is an integrated approach to medical and legal care, better access for people to legal protections because we're capturing them in the healthcare setting, and also ultimately thinking about good health and well-being. So, legal partners bring a lot to the table in terms of being able to address systemic and legal issues, and clearly healthcare providers have much to bring to the table in terms of the relationship that they have with their patients and access. So just to give you a sense of medical legal partnership, when we started our medical legal partnership at Hasbro Children's Hospital in Providence in 2002, I think we were the 5th partnership like it in the country. The first started in Boston. And this is where we are now. We have about 268 medical legal partnerships across the country in about 36 states. But they're partnering with multiple different organizations and agencies. And most notably, law schools are a big part of this, as well as medical schools. So it's I think, an excellent opportunity both to think about how to provide the service and the care for patients, but also to educate students. So how am I doing on time? I want to make sure I don't talk.
You have about 30 minutes left. So it's 11:20, so we get 11:45.
Okay, we need to leave time, 10 minutes. Okay. So, the other question that we often get is, well, it sounds to me like you're dealing with one patient at a time, right? You have a patient come in, that patient or family has legal issues, you address that, but what does this really mean in terms of trying to change systems or change the way that we do things? So the goal of this really is to change healthcare practice by training healthcare providers to identify needs, right? So to understand the child that comes in with asthma needs more than medication often, right? We need to know what's going on in their home environment and to be able to think about interventions for them. So treating patients may involve, legal services and other types of advocacy services for that family. Changing the way that clinics practice, which is, again, how do we link what's happening in the exam room to the community? How do we understand those connections? How do we think about working as a team to address some of the problems that exist for patients? But also, how do we use what we learn through that process about what's going on in the community? How do we use medical legal partnerships as a way to kind of detect broader systemic issues for patients and families and address those? So I'm going to give one example, which is out of Boston, and I'm just going to pause. But this is near and dear to my heart as well, because in Boston, as is true an hour away in Providence, we have families consistently have their utilities shut off for lack of payment because, as you can imagine, with the winter that we just had in Boston and Providence, but every winter, utilities are extremely expensive, particularly for low-income families. And so, when we're having these 18-degree days, day after day after day, and we're running our heat, it's extremely expensive. So if you're low income and you're having to trade off, am I going to buy food or am I going to pay my utility bill? Often the utility bill is the thing that's easier to ignore, and then your utilities get shut off. So what they did in Boston is that they started recognizing in Boston Medical Center this phenomenon, and I won't go into detail. You can imagine the health effects of having your utilities shut off if you're a low-income family, particularly a child with asthma, or the elderly people that are living without heat, people that need electricity for a nebulizer. There's a whole range of ramifications of not having your utilities on. So they started training the healthcare team to screen patients around utility shutoff issues. Are you having problems paying your utilities? What needs to be? What can we do to help you? And there are regulations that protect families from utility shutoffs based on health and income considerations. But often families don't know this, and so having the frontline providers understand this can be extremely important. So this increased healthcare providers' knowledge and willingness to write letters to protect families from the shutoffs. Then they realized that this was happening, patient by patient. So they decided that it made sense through the medical legal partnership to create a clinic, an opportunity for people to come in and get services and support from their healthcare providers and from the legal clinic around this issue, so that they weren't addressing it just sort of patient by patient coming into the hospital. Then they realized that this was this adds a burden to healthcare providers having to, patient by patient, write letters for every family who may be experiencing this to get protections under the regulations. So they put a form letter in the electronic medical record to make it a much more streamlined process so that the healthcare providers could provide the support for families, and this increased 350% how many letters were being written, and 676 families being protected. But they also realized that there's problems with the way the regulations were written in terms of the requirements for families to gain protection under the regulations. So they started to work together to draft joint testimony. And I will tell you, I say this to my medical students all the time, I as a lawyer can go up and speak to the legislature about something, and literally the legislators will be turning their chairs around talking to each other while I'm talking. But when doctors do it, and they come up and they say, here's the impact of utility shutoffs on my patient's health, that gets their attention. So part of what we try to do with medical legal partnership is say, this is a partnership between lawyers and healthcare professionals to be able to use our voices more effectively. Lawyers are really good at figuring out, how to articulate issues, but providers are really good at being able to tell the stories that can really make a difference for legislative change. So they work together on testimony to reduce the need for chronic disease recertification. So families were having to come in frequently to recertify that they had someone in their home with chronic disease in order to protect from shutoff. So thinking strategically about what we learn from patient experiences and taking it, across the line to, to clinic changes and protocols, but also to population health. So I won't go through all of these, but some of the studies that have been done on medical legal partnership outcomes have shown better compliance with healthcare, better health in sickle cell patients, also in asthma patients, decreased stress, and I won't go into it, but there's a lot of really interesting information out there now about the role of stress in health, toxic stress. And so one of the things I think that this can help with is giving people a sense of empowerment, or a sense that they can do something about their circumstances. And I think that can be extremely powerful and probably health promoting at the same time. Savings in healthcare costs. This is a huge discussion, and I probably won't have time to go into great detail about this, but helping to think about when you intervene in these ways, how are we reducing the asthma hospitalization down the road in order to reduce healthcare costs. Certainly better knowledge and screening by providers, and just better satisfaction, more satisfaction for providers who feel like they have the resources that they need for their patients. I'm going to skip those. So I want to just finish up by talking about a particular study that was done at a medical legal partnership in Cincinnati, at Cincinnati Children's Hospital, kind of looking again at this idea of detecting the problem in the clinical setting and then taking that to the community level. So some of the physicians at Cincinnati Children's Hospital began looking, and a lot of this is about mapping, right? Understanding where are your problems. Looking at asthma admission rates for children, but these are neighborhoods, you probably can't really read that, but we know that there are worse problems in certain neighborhoods with asthma hospitalizations. At the same time, they have a medical legal partnership. A patient came in with a child with asthma and presented this letter saying, I've been told by my landlord that I'm not allowed to have an air conditioner. Well, air conditioners dry out the air and can help protect against some of the harmful triggers for asthma. And so they started to identify some of the problems that families were having in terms of housing issues.
So they referred this initial case to the Medical Legal Partnership, but they started to see a trend of families who had kids with high risk for asthma hospitalizations and lead poisoning, and they started working as a team to look at the problem. And in this case, all of the patients were African American and were on Medicaid. And as the Medical Legal Partnership attorneys started working with these families to find out about their housing conditions, they realized that they were all living in 19 complexes owned by one owner. And all of them had outstanding housing code violations that had not been enforced. So this may be a little hard to see, but again, the benefits of mapping, they started looking at the neighborhood level, where the cases were coming from, the location of the buildings, and just sort of access issues. So what did they do? They went to work advocating with city code officials. In this case, there were citations for many of these properties, but nothing had been done about it. They took court action against the landlord. They also went more broadly into the community, testifying at city council meetings about enforcement issues around housing. This one I love. They helped to create and began to represent a new tenants association for people in these housing units. And so, they didn't sort of stop at the individual. They looked at this community level health threat and recognized both that they could do legal advocacy on behalf of individuals, but also thought more broadly about some of the ways that they could begin to push the enforcement systems better. So I won't go into detail, but they of course found all sorts of housing code violations in these apartments, and were able to either get repairs made or get people moved into more environmentally safe places. So I'm going to take one more minute. Is that all right? Okay. I'm going to just talk briefly about this is connected to Medical Legal Partnership, but I think it's another really nice model of thinking about how do we cross healthcare with other entities to begin to connect the dots for families. So this is something called Breathe Easy at Home. Started at Boston Medical Center. We actually have it now in Rhode Island through the Rhode Island Department of Health. And the idea is that healthcare providers who think, based on talking to their patients, that there may be housing code violation issues, can electronically connect directly with inspectional services. In Boston, it's called inspectional services, so housing code enforcement. So that we're not sort of telling the family to go home and call housing code because you may have a housing problem. The health provider is being proactive about this. So you can see it's an online system where they can make a direct referral directly to housing code. And the other nice part is they continue to update the record back and forth. So there's, when the Housing Code Inspectional Services has taken action, there's actually, it's updated in the record so that the healthcare provider, if the patient comes back in, they can see what's actually happening, and if nothing's happening, they can help to continue to advocate that something happened. So at Boston Medical Center, you can see it changed provider behavior because these are referrals. From the time that they started, I think it was in 2006, all the way up to 2013, the increase in the number of referrals that they're actually using. The other thing, and I know that ChangeLab has written about proactive housing code enforcement. The other thing Boston has done is they passed an ordinance to have units inspected every 5 years. So typically, when you think about the way we do things, we wait until somebody has a problem that's identified, and then we may go and do an inspection. But this is a proactive approach, which means that we're consistently looking at housing conditions for people and not waiting until we have to identify the problem. Right. I'm going to skip through these. So there's information about the National Center for Medical Legal Partnership. If you're interested, you can go to their website. They have really terrific information and toolkits and things like that. So thank you.
And they're both now now the speakers are both going to sit here in the front if anybody has questions for them. We have about 10 minutes or so for questions and answers.
Change names.
I wanted to provide a point of clarification about my comment on smoking and the mentally ill. Is that as a group, they're a very vulnerable population. And they die 25 years prematurely compared to you and I and other persons with other illnesses because of their increased rates of cigarette smoking. So we diagnose sometimes by zip code, but persons with mental illness as a group with a medical diagnosis, they also are a very vulnerable population. So that's one of the issues. And so when people reacted with laughing, I wanted to make sure, wait a minute, let me make sure I give the context for my comments to let you all know that. Thank you.
Yeah, it really brings up an issue too that we haven't talked about, which is behavioral health services and the tremendous lack of access for almost everyone, but particularly in low-income communities.
Piggybacking on mental health issues are some issues that we often neglect. But other communities using, say, optimal defaults, that helping the choices, the easier choice in regards to mental health issues, and what communities are actually doing that in an effective way.
Yeah, I do want to draw your attention to this paper. There's copies someplace right here. Right there, from Pediatrics. It just came out this last month, and it's called Neighborhood Adversity, Child Health and the Role for Community Development. Now, just tying it into the conversation, I'm not a mental health expert, so I can't talk too deeply about it except to recognize that it's a huge issue. But what we're learning is there's this concept called Adverse Childhood Experiences, ACEs. Centers for Disease Control and Kaiser Permanente, which is a huge medical delivery service in California, have teamed up, and they've identified stressors that if in the first 5 years of life, even pregnancy, so what we're calling with Robert Wood Johnson is P through 5, those first years of life, so I guess it's 6 years almost, when the brain is developing, when you are exposed to stressors, family violence, alcoholism or drug addiction, poverty, marital discord, there's a whole list and it could go on. Those adverse childhood experiences actually shape the way the genetic code is expressed or limited. And what this study, it's very powerful evidence, what this study shows is that children who have 4 or more of these stressors, and you can screen for it, and are at extremely high risk for dropping out of school, for mental health challenges, for ending up in jail, for chronic disease, tobacco use, obesity, diabetes. The death rates are extraordinary, and when you look at the zip code versus genetic code, a lot of what you're seeing are these ACEs, adverse childhood experiences. This paper makes the connection not just to those interpersonal family experiences, but to neighborhood experiences, where the neighborhood itself becomes a toxic stress. As Sharon said, you're walking to school and you're afraid, day after day after day. That affects you. It affects your mom, who's worried about you out in the neighborhood, walking to school or playing. If there's no job opportunity, it affects the whole community. It says the findings suggest fully 1/4 of differences in health to mid and late life can be attributed to neighborhood differences during young adulthood and even childhood. So access to behavioral health services is huge. It's a real problem nationwide, and we don't have this parity between medical care delivery for physical and mental health. We've got that. It's a challenge in the Affordable Care Act and across the board. But there are ways that in doing our transportation system, our park and rec, our land use, our public health, that we can be addressing later in life behavioral and even in childhood, acting out in schools. Instead of saying, what's wrong with you, ask the question, what happened? What happened today at home? What happened on your way to school today? Did you get anything to eat or not? And find out when those interventions, there's big interventions. I know the California Endowment in California is really moving into this space with high schools. Instead of disciplining kids and putting them on suspension and out of school, they're doing wraparound, because that's the pipeline to jail for kids, and that's a pipeline to never getting a job or being a dad or a mom who can provide for a family. It's a total pipeline to get kids out of school when they've got behavioral problems. How do you keep them in school and change the environment that those kids are working in and do more surround sound? This is behavioral health in a social determinants of health context.
If I could just tell people in the room about a couple of things that are going on in Memphis.
Please, yeah.
There is an ACE task force in Memphis that's looking at, they've done an ACE study here to see,
Great.
and of course it's startling. I mean, people have had adverse childhood experiences, and so they're opening up a couple of centers, one at the Baptist Hospital and then one at Knowledge Place. And that's meant to be a support to families and parents and children. And also, Lamar and Shelby County government are the lead agencies for the Early Success Coalition. And we have a demonstration grant from the Tennessee Department of Health. And one of the things that we're doing is looking at how we can integrate mental health services or consultation in child care centers. Because we believe that
That early age,
yeah.
yeah.
So we're working on that, and we hope to partner with more and more people.
Yay.
Hi, thank you to both of the presenters for your presentation. Really enjoyed the information and seeing more of the projects. But my question goes to Marcy, because we changed the last. My question is about two questions about the first two processes you mentioned. The step one, convene and collaborate. I would like to know if you can kind of share some best practices, because in my experience here in Memphis, I'm learning that we oftentimes work in silos, and that there's no real communication or a tool or platform for us to figure out who's doing what, so that we can collaborate. There's this do-good spirit, I guess you could say, that we want to collaborate, but if we don't really know or inform the who's doing what, then how can that happen?
Right.
And then the second question is to step two, engage in vision. How do you go about selecting the tools that you use? Because there's no one size fits all. So you have to be strategic but culturally sensitive to the uniqueness of each group and community.
Well, there you just gave an answer to the second one, which is yes, you're right. But let me see if I could back up. So a couple of best practices, and we're actually writing a toolkit right now that we hope will be out by the end of June, but it'll probably be September or December, the way these things go. But just stay in touch with our website on how do you actually do health in all policies. We'll say that there are some good tools out there, but it takes... To start with, it takes leadership. It's coming out of the mayor's office or the city manager's office, however you're structured here. It takes people, it takes leadership saying, I am holding you accountable to this. So I can talk about the city of Baltimore. The mayor there, whose name I forget, woman, has said, I want this to happen in Baltimore, and we are going to set metrics to measure. We're going to have a plan that has metrics in it, that you, as the head of the transportation agency, the Park and Rec department, are going to be held accountable for in your performance reviews and in how we make budget decisions if things are tough. I want to see a plan, and I want to see action against the plan, and we meet monthly and we measure that action. And you are accountable not only to me, but to your peers, because we're talking around the room, and we can see if you're making progress or if you're getting stalled. And if you're getting stalled, what can we do to overcome those barriers with you, or, kind of goose you if there's no barrier there, just a lack of action because there's a lack of commitment. And then you back that up. I mean, it's not always pretty, but it takes leadership. And it takes training. People have to learn how to work together. We are so siloed. I mean, as I said, school of public health and city planning as far away as possible. Public health and city planning was the same thing in the 1880s. Clean water systems, disposal of trash. This is city planning. This is public health. They're the exact same thing. They're inseparable. And now we're as far away as possible on a campus. We don't even have the same language. We don't even know each other. So there have to be opportunities for sharing common goals and saying, what can I do about that? What's my expertise? The community engagement, you're exactly right. My suggestion is the city, I'm from the government, I'm here to help. It's better than not being there for sure, but really, and this is where take some money. You put money into trusted community-based organizations who live and breathe that neighborhood's life, and they are your leaders in community engagement. They'll know. They'll know.
Can I just add something to the cross-sector communication? I'm a big proponent of starting during education, of teaching students how to communicate with other professionals. We train, especially, law students. I used to say this to my law students all the time. We train you how to speak a certain language. And then when you go out in the world, you're talking to a doctor, or you're talking to a nurse, or you're talking to a planning person, you don't stop using that language, right? That's the language you've adopted for your profession. So we have to think about how we, cross-train our professional students to be able to communicate and collaborate, because often when they get into the systems they're working in, it's much more comfortable not to do that. So I just would add that.
I have a question about that legal model, and I'm wondering if there might not be potential for actually taking paraprofessionals who are actually working in community health workers and actually training them to identify conditions in the community, legal issues that exist in the home, and then tying with that to the controls of enforcement or that legal model. And that way you're actually penetrating deeper into the community. And so that's one question. The second question is, in your Boston example where the code enforcement cases went up and up and up, which was great, is there any feedback at all in that system for showing that the benefit of reducing those PD visits, PD is going down? Is there a feedback to provide more funding to code enforcement so that they can actually address those issues?
No, but I think, that is a conversation that's starting to happen, which is, particularly in the healthcare sector, which is, let's start measuring interventions that have to do with, community-based interventions, for example, around asthma. So if we start measuring the impact of remediating homes for asthma triggers, and we measure how many reduced hospitalizations we have, or we're also measuring, school absenteeism. Are we reducing school absenteeism for kids? There's something called social impact financing, which is a new model to, get private sector investors to invest in interventions, study those interventions to see if they have a return on investment, and then, putting some of that money back into the intervention. So there's new, I think, structural ways that people are starting to talk about that. Your first question is an excellent question, and I think that's absolutely, particularly with healthcare reform, where medical legal partnership is heading, which is thinking about this team, right? It used to be, and frankly, it's called medical legal partnership because we started with doctors and lawyers, and now what we've done is really looked at, where do lawyers fit into the team, and absolutely critical to that are community health workers and other people on the ground. So that all of these professionals, we like to talk about people working at the top of their license, right? We want the doctors doing what they need to do. They need to understand these issues, but they can't do it all, right? So having, a community health worker who is gathering information, and then when there's a real legal intervention that needs to take place, they're working collectively or collaboratively to do that. So yes, that's definitely where we're headed.
All right, thank you. I hate to cut off the conversation, but guess what? We anticipated that you all would be juiced up and want to keep talking. So we have lunch now for you, Bonton Cafe, and we have lots of different options up on the 4th floor reading room. If you want to go this way, as Beyonce would say, to the left, or for you, it's to the right. It's about as cool as I can get. I said the name right, though. So if you go out that way, the elevator will take you to the 4th floor. And up there, we have some affinity tables. Dr. Juarez with UT Health Science Center will be at one. You'll see that there's some tables with table tents. We have community engagement, role of law policy, working across sectors, financing the work, and mapping the data. I encourage you to go up there and while you eat, chat and make new friends, and be back down here Try to leave that area by 12:45 because we're going to, you know me, we're going to start at 1. All right? Thanks, everyone. Thank you to our speakers.
Spend some time in Spain, spend some time in Portugal, study abroad kind of thing.
Well, we can't.
He's been wanting to go abroad for that, so this is his summer junior and senior.
What's up, brother?
He's having a great time.
I'm just trying to see who I am today.
Yeah. Where's Robert?
We're just going to get started.
These are just lies.
Thank you, everyone. This is David Waters' show now. I'm going to turn it over. I just want to thank you for making it back this way, and now pivoting with us as we go from the wonderful national context to what's going on locally. And with that, I give you the Faith and Health panel.
Hello, everybody. Can you hear me okay? If you can't hear me in the back, just throw something. We're here to talk about faith and health, which reminds me of a story I heard from an old Greek priest many of us know and love. A doctor and a nurse and an HMO executive all happen to die on the same day. And so they all end up at the pearly gates at the same time. St. Peter comes out to meet them and asks them what they've done with their lives. And the doctor says, well, I've spent my entire life devoted to helping the sick and the poor. I've helped thousands of people heal and get health care, lead healthy lives. St. Peter says, great, come on in. The nurse says, I've devoted my entire life to helping the sick and the poor. I've helped thousands of people heal and get better and lead healthy lives. St. Peter says, great, come on in. The HMO executive says, well, I ran a large health maintenance organization. I helped millions of people navigate the healthcare system and help them with their healthcare options. And St. Peter says, come on in, but you can only stay 2 weeks. We laugh because we hurt. We know how complicated it has gotten. We also know that much healthcare used to be provided a long time ago by faith-based organizations, started by nuns and priests and ministers and rabbis and brothers and sisters and lay people. We've had, and we still have, Catholic hospitals and Jewish hospitals and Methodist hospitals and Baptist hospitals, and you name it, we've got it still. The Red Cross is still here. But so much of healthcare has changed and moved away from those faith-based origins. And so now healthcare has become so highly specialized and regulated and financed and insured. And our communities have likewise become much more complicated, more interfaith, more ecumenical, more secular. So where does that leave the faith community in its role in the healthcare world? What is the role of the faith-based community? What is the faith-based community doing right and doing well? What are we doing enough? Is the faith-based community doing enough? What are we doing wrong? Where are we failing? Where are we coming up short? What can we do better? What can we do more of? And how do we start? And we're going to start talking about that with an incredibly esteemed panel of folks. I'm going to keep the introductions brief so they'll have more time to talk because they know stuff and I don't. I'm also going to keep it brief because if you're from Memphis, you know these folks, and you know, in all objectivity as a journalist, I can say how blessed we are to have all of these folks here in this community. And, you know, the Grizzlies have 3 All-Stars. We've got at least 6 right here. I'm going to start, and I'd like each of them to sort of take a little time and just tell you about what they do from in a faith-based role in the healthcare world. And maybe they could be specific about maybe one project or one program that they're in touch with to kind of help us put some faces and some flesh on this issue. Sally Jones-Hines, to my immediate left, is the executive director of MIFA since 2011. Before that, she was vice president of development. And her father, if you may or may not know, was Paul Tudor Jones, the legendary pastor of Idlewild. Your uncle, I'm sorry. Paul Tudor Jones, the legendary pastor of Idlewild Presbyterian Church and a co-founder of MIFA, is that right? She's been in the nonprofit world, the academic world, the corporate world, and she comes at this from many perspectives. Next to her is Rabbi Hannah Leslie Glazer. She's a senior rabbi at Beth Shalom Synagogue with her husband, Rabbi Ilan Glazer. They've been here since 2013. She's also the founder of the Philadelphia Emerging Religious Leaders Program. And for 15 years, she spent her time as a journalist, an editor, and a foreign correspondent for many publications, including Bloomberg News. She finally saw the light and got out of journalism. I wish she'd called me.
Be like which light?
Good point. To her left is Reverend Dr. Kenneth Robinson, MD. I'm not sure if or when he ever sleeps. He's the president and CEO of United Way of the Mid-South since last month because he didn't have enough going on in his life. He was the Tennessee Commissioner of Health from 2003 to 2007. He's been public health advisor for Mayor Luttrell since 2008. He is the chair of Healthy Shelby. He also happens to have a little part-time gig as a gospel minister and co-pastor of St. Andrew AME Church with his wife, Dr. Marilyn Robinson, who's also an executive at St. Francis. To his left is Reverend Keith Norman. Keith's also a busy guy. He's the first vice president of government affairs for Baptist Memphis Healthcare. I think that's the official name now. He also happens to be a gospel minister. He's the pastor of First Baptist Broad since 1999. And he's been a huge part in his congregation. I've had a lot to do with the revitalization of Binghamton over these years. He also happens to be the president of the Memphis branch of the NAACP. He's also a chaplain with the Shelby County Sheriff's Department. He's working on his doctoral degree at MTS. And his wife, Alicia, is the principal of Perea Preschool, which is connected to Church Health Center. To Keith's left is Reverend Dr. Harry Durbin, Senior Vice President of Faith and Health at Methodist Lebanon Healthcare since 2014. Methodist Lebanon and Harry have done a lot in terms of working with the connection between faith and health in this community. They've done great work. They've worked on the Congregational Health Network, which I think Harry's going to talk about, the Living Well Network, the Clergy Coaching Network. I could go on. Harry's also a gospel minister and ordained elder in the United Methodist Church. His pastor churches in Collierville and Cordova and other places. And way down at the far left is Reverend Dr. Scott Morris, also MD, founding director of the Church Health Center since 1987. And he's going to be big part of the revitalization of the Crosstown neighborhood. He was also founding director of Crossover Health Clinic in Virginia before he came to Memphis. He's also a gospel minister on the staff at St. John's United Methodist Church. And he's on the board at Healthy Shelby, and I could go on and on with all these folks. They are doing so much in this community. It never ceases to amaze me. But we're fortunate to have them here, and they honestly can tell you more than you ever want to know about the connections between faith and health, what works, what needs to be done, and why. And so we're going to start with Sally. Go right ahead.
I do have ministers in my family. We do.
Credit. We'll pray for you.
I am the executive director of MIFA, which is the Metropolitan Interfaith Association. MIFA was founded in 1968 in the aftermath of the assassination of Dr. Martin Luther King Jr., and it was founded by a diverse group of lay and community leaders who came together really because congregations and leaders of congregations had seen that it was difficult for congregations to impact the social issues that were prevalent and disturbing in the city, poverty and hunger and homelessness. So MIFA was created in large part to provide an avenue for action for congregations. As MIFA began as an advocacy organization and since has moved into direct service delivery, but we still rely on the faith community to help us with the delivery of many of those services. Today, our mission is to support the independence of vulnerable seniors and families in crisis through high-impact programs. Our programs are really about helping people live independent lives with hope and dignity. And for today's discussion, I would like to concentrate on our program Meals on Wheels, which is a program that most people are familiar with, and you may have experience with it here in Memphis or in your own community. At MIFA, our Meals on Wheels program, we prepare 1,200 meals every weekday, Monday through Friday, and about 800 of those meals are delivered to seniors in their homes. The others are taken to congregate sites like Orange Mound Community Center, where seniors gather to eat together. Most of our home-delivered meals are delivered by volunteers. So we're doing 1,200 meals a day, but we expect that the need in Shelby County is really more that 4,000 seniors are at high risk of food insecurity. So there's a lot more need than we are able to meet at the moment. Meals on Wheels is funded through the Older Americans Act. So it is federal mostly. We also have to raise a great deal of private money, but it comes down from the federal government to the state and then to the county and then to MIFA. And as you might expect, there have been cuts in that funding. Sequestration, we lost about $300,000. And every year, this year, I think we're going to get a 1% cut. And at the same time, costs for meal preparation and et cetera increase. But Meals on Wheels is really about more than a meal. Research shows that in addition to improving nutrition, seniors who receive a hot home-delivered meal every day, every weekday, show reduced hospitalization, reduced visits to rehab than similar seniors. But what research is just beginning to show is that that daily delivered meal can also impact social and mental health issues like anxiety and depression and feelings of isolation. And seniors who receive those meals report a higher feeling of safety at being in their home. So it really is more than a meal. It's important in so many ways. And it's important for the volunteer. There's also just a cross benefit from the volunteer who is delivering that meal. One model I wanted to mention, Kingsway Christian Church in Germantown has adopted a meals route. They have actually raised the money in their church to fund a meals route near their church, and they have 30 volunteers, and they trade off delivering those meals every day. And the stories that are coming out of that congregation with the relationships they have made with the clients they deliver meals to, and actually in one home they saw there's a need, we need to raise a little more money because there are actually 2 people in this home who should be getting meals. So we're excited about that model and excited that both the volunteers and the clients benefit from this interaction. I mentioned the funding cuts as I end. I just want to say on a positive note, we're very pleased because the Plow Foundation here in Memphis, through their Aging in Place initiatives, have funded with close to $4 million a grant to increase our nutrition interventions for seniors. Yes. It is. It's also exciting because it's a collaboration. It's MIFA, but with 7 other partners: the Jewish Federation, Catholic Charities, Baptist Healthcare, Methodist Labanner Healthcare, the University of Memphis School of Public Health will be doing the evaluation for us, and the Aging Commission of the Mid-South and the Mid-South Food Bank. We'll be experimenting with different deliveries, and one thing that's real exciting is that we hope to have pantries at the hospital so that when senior patients are discharged, they don't go home to an empty cupboard. They can take some food home with them. So there's a lot of exciting things about that. We'll need more volunteers, and we can talk more about that later if there's time. But thank you very much.
Thanks, Rabbi.
Thank you. Thanks very much for the invitation to speak today and join this very distinguished panel. So I also do not have a concrete role in a Memphis clinic or a hospital, as some of our other speakers do. And of course, if I'm representing the Jewish community here, there are many Jewish individuals who are involved in public health and advocacy and health policy. But in terms of organized work that's Jewish, one of the things that I thought it would be good to speak about is something that we're doing through our synagogue that I participated in directly this year for the first time, which is a congregant of ours who runs an annual medical mission trip to Nicaragua, to the country of Nicaragua. And it is only one of a handful of Jewish medical mission trips to that country. And participating in it got me really thinking about the nature of faith-based service and faith-based justice work, and so I thought I would share about that here. A little bit about our trip. It is organized privately through this congregant of ours. Her name is Tricia Mandel. She's a social worker with a hospital background. They have a 501c3 that they've opened for the purpose of running these missions. The name of the organization is called Tikkun Olam Nicaragua. Tikkun Olam in Hebrew and in Judaism means a few things, but in this case it's a reference to the most common translation that you will see out there, which is repairing the world. So Tikkun Olam is most often used to mean repairing the world. In Jewish circles, it serves broadly as a term for the actual engagement in social justice work, and not just the talking about it, but also the doing. And one of my most important teachers in this area, Rabbi Mordechai Liebling, talks about Jewish faith-based social justice work as organizing the pursuit of justice rooted in Jewish tradition, fueled by caring rather than rage. So the concept here, though, is that it's not just about caring, that there should be a concrete component of action that goes along with the caring. So our trip was called Tikkun Olam Nicaragua, Medical Mission, and we were doing something concrete there in the area of healthcare. This year was the 5th year of mission trips by this particular organization, all to Nicaragua. The trip is organized through a Christian agency called Globe International, and they use 2 orphanages that they have in Nicaragua as a home base for running medical missions, mostly, as I mentioned, all Christian. And the missions generally have a standard structure. They bring doctors and nurses and pharmaceuticals and medical supplies to offer medical care clinics to areas that don't have adequate access to health care. There are translators who join the group. They sit with the doctors and they help bridge the language differences. The idea is that they go to a different site every day and they serve as many possible patients as they can over the course of that day. And of course, depending on how many providers you have and how many pharmaceuticals you have and supplies you have, that's how many people you can see. So this year, we went with over 5 doctors and nurse practitioners who are our providers. We had translators for each of them, plus a Nicaraguan pharmacist who oversaw the distribution of the pharmaceuticals that we had very carefully brought. I served as the group's spiritual leader, and I had a translator assigned to me also, even though I worked in Latin America for a long time and I speak Spanish, but it was nice. Another 6 Americans came along as support staff. We were 15 altogether. And the support staff would help take blood pressure and other vitals. They would work as assistants in the pharmacy. They would do intake of names, etc. We also brought along 500 pairs of work boots that were distributed in the country, 250 pairs of gently used sneakers, more than a dozen handmade shawls, little stuffed animals for all the kids, lots of pictures of that. Really importantly, more than 500 pounds of medication and medical supplies, and 4 tons of food. Rice, beans, salt, powdered soups, all that was purchased over there in Nicaragua. Overall, we saw about 1,000 patients, more than 200 per day for 4 days of clinic. And so I wondered, why go to Nicaragua to provide health care? And I asked. And so I asked the Nicaraguans what good we were doing there, and wouldn't it be better to send our money rather than to send ourselves, and couldn't that money do more good there? And interestingly, you know, some of the answers I got back, Nicaragua is the second poorest country in the Western Hemisphere, behind Haiti. It is a difficult place to live. They have a great brain drain, many educated people who get out as soon as they can. The country offers its citizens universal health care, and it is working to improve its coverage. But the country's medical coverage there is quite poor now, and there are people who are suffering and needing help right now. Children in rural areas who are born with heart defects, who need help getting connected to a cardiologist in the capital, people who need blood pressure medication to prevent a stroke, but the local health center is out of that medication. There was one woman who was tormenting herself because she was getting goosebumps when she got cold and she didn't know what it was. And there were people there who we could help concretely and save lives now. So then I asked one of our medical providers on the other side, I asked one of our medical providers on the team if she also works in public health in Memphis. So if Memphis is one of the poorest cities in the country, couldn't we be offering those same pop-up Jewish clinics at home? So, and I've heard this before in other congregations that I've worked in other states who have said we should do this, that this is something that a congregation should offer, a pop-up medical clinic. But it was interesting, when I asked this particular medical official, her answer to that question, interestingly, was no. And she said there are plenty of Jewish doctors already working in the public health sector at the institutions that already exist. And she already sees Memphis as so well covered by the existing faith-based institutions that are already in place that she chooses to go somewhere that she sees as poorer than Memphis, with less access to health care than Memphis offers, rural Nicaragua. So it raises a question for me, whether you agree with her assessment. I'm open to some consideration of that.
No.
Do we see Memphis as adequately served by the coverage that we have and the institutions that we have in place now? And how much actually is adequate? So I've been talking for a while. One of the other things that I would love to talk about, and we can address that in questions if you're interested, is how faith-based healthcare gets provided. And so that was something that we really needed to look at, especially me as the spiritual leader of this group, is what was my mission there, what was my purpose there, and how are we working as a Jewish group as opposed to some of the other groups that have been there that were Christian. So I'd be happy to address that in questions. Thanks.
Good afternoon. David has asked us to talk about our story. I have a little bit of a personal story and a little bit of a congregational story vis-a-vis my role in terms of faith and health. A funny thing happened to me after I entered medical school. The summer after my first year in medical school, my life took a very unexpected turn. I had always wanted to be a doctor. I had studied to be a doctor. I was at Harvard Medical School, and the summer after my first successful year, God called me to preach. So by the second year of medical school, as I put my white coat on for the very first time, I began to struggle and ruminate and meditate about what this must have meant to have been in medical school and also called to preach. And I started thinking about my own calling to both medicine and ministry. And I became more and more convicted by what I was seeing in my patients. Not long after learning how to do a physical diagnosis, I ran into the awareness that the problem behind the chief complaint, the reason that people are presumably coming to see the doctor, was much more found not in their history of present illness, the things that they teach medical students to pull out of patients, but it was in their social history. And I realized at that point that the overall health of individuals, not just their health care, was being significantly and adversely affected by what we would consider today social determinants of health, macro environmental factors such as poverty and oppression. And so that interrelationship between biology and behavior, the impact of the physical environment and the social environment really impacted me as I started thinking about what it was I was called to do. Now understand, this was almost 40 years ago. Look at your neighbor and say, long time, long time, long time. And so my story is that my calling was not only to change individuals' lives, not only to be sitting in a physician's office in that patient-physician dyad, which I enjoyed for the 10 years that I practiced internal medicine down at Vanderbilt before I came here, but my calling was really to change systems, that the solution to the provision of health, that the solution to health of individuals lay somewhere not in the doctor's office, not in the emergency room, not in the hospital, certainly not with the HMO, but somewhere out there in the community. So I've been trying to do that. My personal story is that for me, impacting the health of communities, changing systems has come really in 5 different ways, and I toss these to you because some of you are at formative points in your own careers and you're thinking about how you might use your law degrees, how you might use your extraordinary education to impact the world and hopefully to create healthier communities. I sought to contemporize medical school admissions, producing a diverse and culturally competent workforce. African American physicians go back to lower socioeconomic status communities at the rate of 4 to 1. The world was changing. Secondly, creating new conduits for federal, state, and local public funding for faith-based programming. Creating some credible congregational models of social service and health and human service provision. Third, translating the goodwill of private philanthropy into the praxis of capacity building, community changing, life ameliorating ministry. Philanthropy wants to do this, often did not know how to do this, and did not have the appropriate subjects, the appropriate entities, the appropriate agencies with which and through whom they could exercise their health-generating philanthropy. Fourth, directing public health resources towards truly saving lives, reducing the number of premature deaths from preventable causes, reducing the startling racial and ethnic disparities that are so prevalent and obvious in places like Memphis, Tennessee. During the 4 years David mentioned that I had the privilege of being the health commissioner for the state, redirecting public resources, public funds to really, newsflash, change lives and to put resources into communities that had the greatest need in terms of improving their health. But lastly, my calling has been primarily translated into joining my partner in life, David, yes, Marilyn Robinson, who is out at St. Francis Hospital as Senior Vice President, but is also the other half of our pastoral team at St. Andrew, in transforming what I call hibernating inner city churches into vibrant engines of community revitalization, with the express purpose of improving the health of the community, of building healthy, sustainable communities. My argument has been, and Scott and I have been on the 1-2 stump 1,000 times, our issue is that churches are social service agencies in communities and ought to be able to really revitalize those communities. And so we assume the pastorate of an inner city church, not in the suburbs. We have the privilege of leading a great congregation that addresses those social determinants of health in South Memphis, St. Andrew AME Church. So today, our congregation is doing it in some very practical ways. We give out more than 30,000 meals a year through our food bank site. We annually donate this year over 1,400 pairs of shoes for children who are often truant at the beginning of the school year because they are embarrassed by their footwear. We opened a community library for children, understanding that education makes the difference. Filled it with 2,500 books, now children can walk to our community library. We provide an after-school safe place with a computer bank and academic programs and an athletic ministry. It's why we founded our Community Development Corporation. We bought up distressed property, demolished crack houses, built an apartment community, high-grade, Class A affordable rental housing for 80 families, built 36 single-family houses. We've qualified hundreds more for home ownership and have kept hundreds from suffering foreclosure. And notably, I think we have developed a pipeline of high-quality education from pre-K, from childcare through pre-K, through our nationally accredited kindergarten through 5th grade elementary school, the Circles of Success Learning Academy. Finally, I just wanted to mention that we do have the South Memphis Farmers Market on property that the church owns, and with about $400,000 of local foundation support and $888,000 of federal government and Obama administration support, we opened a small fresh fruit and vegetables and fresh wholesome meat grocery store with a demonstration kitchen right there on the corner of South Parkway in Mississippi. Health, housing, education, income, social determinants of health. That's my story. I'm sticking to it.
What he said. Yeah, that's what he said. That's it. So, my name is Keith Norman, and oftentimes I have to turn around my nameplate to see where I'm working today. But of the three things that I'm most passionate about, they're really all perfectly aligned in this particular forum. I serve as the pastor of First Baptist Church, president of the NAACP, and vice president of government affairs at Baptist Memorial Healthcare. I'm the evidence that God has a sense of humor on this panel, because after a 15-and-a-half-year career in hotel development, my work began in ministry in Binghamton. And the first thing that I did, because I'm a numbers person and because I've worked with rebuilding organizations and organizational management, was to do a survey. And I walked through the community to see what the epidemics were in that particular area, where 14,000 residents had been a part of the community and it had dwindled down to 8,000, and many of them were living way below the poverty line. And so we began to find that teen pregnancy, poor health, and aging population, poor transportation, that you can't catch a bus anywhere in that particular area and get to healthcare, shopping, grocery stores, whatever, and poor food access were the things that really were impacting our community. And so when we began to look at the 38112 census tract, we decided, this is our ministry. You don't have to go out and create anything when you see all of those determinants right there at your door. And so we began to list those things as our targets for that particular community. And in working there, what we began to discover is that we could not do it all. So through an effort of collaborative outreach, we began to reach out to partners. We began to partner with clinics. We began to partner with other agencies to really bring services into the Binghamton area. I'm very proud to say that we've been the largest investor over the last 15 years in all of the revitalization of Binghamton, with over $40 million worth of revitalization in community, cleaning up, tearing down, buying, you name it, we do it. Our reach is probably impacted most in healthcare, because what we did was decided to make room for a clinic on our property, because we recognized that we could not, keep up with the requests that we were getting in terms of helping people to really fight through the epidemic of what they were suffering from. A part of the work, and the reason I call this really the trifecta of what I love to do to align the work of the church, social justice, because I really believe healthcare is a major social justice issue, and the NAACP works in that area as well, and Baptist Memorial Healthcare. But this is the trifecta for me, because I get to do all three of those things really under one hat, and it works so well together. Part of the work with the NAACP that we do is really changing mindsets around religious thinking as we deal with the epidemics that impact the people in the communities that we serve and where people worship. I'll use just one illustration, HIV. Obviously, you have to change a lot of mindsets, because there's so many people who hold on to old ways of thinking and really won't talk about this epidemic over the pulpit, where the people really need to hear it from, and how to access care and get all of the things that they need. And so we began to do this work by saying, we have to step out and lead. Several years ago, we conducted one of the largest millennial impact initiatives in Memphis by having over 700 young people tested in the church on a Sunday. And when that was televised and it was put in the newspaper, we began to draw national attention, because people began to see these people are really serious. And me being the first person to be tested was the thing that really encouraged the rest of the young people to follow in line. This testing went on. We gave up a Sunday service. And, with no preaching, no singing, no anything, just a long line of getting tested on that particular day, until Shelby County ran out of test kits on that particular day, because we had more people to be tested than we had kits available to test them. And so that was one of the things. And we took that work and decided to spread it to churches. But we found that churches were resistant to get on board. They didn't want to talk about it, didn't want to deal with it, because they wanted to say this is a disease that impacts other people or different people of a different persuasion. And so I said it was time out for us to hiding from this issue, and let's bring it out front. We do all of the other things, and I think we could repeat those things over and over again. Basically, what I did was take a page out of Ken's playbook and just do it just on the other side of town. I asked him to stay in South Memphis and not come to that side of town. So we do it that way. But again, to show you the impact of it and meeting people where their needs are, in 1999 there were about 60 people at First Baptist Church. There were crack houses, drug-related stores, you name it. You could find everything bad within a stone's throw of the church. The youth ministry at my church looked like 4 kids, and they were all mine at that point. So there was nobody there younger than 30 at that point, trust me. And that was me at that point, so I need to go to show you. I really do think God has a sense of humor. But we began to really meet the need of where people are. Where are you? And by touching those lives in that capacity, it's made the difference. And so we chose to stay in the inner city. We chose to improve the things around us by either saying we're going to buy it and fix it, or we're going to invite someone else in who will be a responsible landowner and tenant holder in that community. And you see the transformation of what's taking place as the work of God shines brightly. That's it.
I'm Harry Durbin with Methodist Upon Healthcare. And a couple of quick observations. One, amazing work is happening in our city. Thanks to all of you and the leadership that you give. My second observation is I probably need a couple more jobs. I thought what I was doing was full-time, but I really need to spread out a little bit more. Many of you know the history of Methodist. We began a little over 100 years ago. There was a Methodist family in Mississippi, John Sherrod and his family, who recognized the need for health care that could be provided without regard to cost, and that everyone would be cared for. So it took some time for that vision to grow and to develop, but eventually the Memphis Conference, the United Methodist Church, the Mississippi Conference, and the Arkansas Conference, they agreed that we needed to start a hospital where everyone could be treated, and that was the beginning and the birth. And if you wind forward now for 100 years or so, a reality that became a part of our work starting in 2006 was the development of the Congregational Health Network. This grew out of a common concern around Methodist South Hospital. Bobby Baker was our chaplain there, Reverend Bobby Baker, and there were interested pastors who wanted to see if we could connect the work of churches and hospitals to promote better health in communities and faith communities. So that work has flourished. Gary Gunnarsson was here to help lead and develop that work. So today it results in about 580 congregations who are in covenant with us, with the hospital system, to promote good health. The member congregations sign up their members to be a part of the Congregational Health Network. They're tagged in our systems. We're able sometimes to provide care even before they come to the hospital. We provide care while they're in the hospital and post-care to utilize the resources and assets of faith communities hooked to and connected to the resources of Methodist and our partners in many aspects to promote better health for our communities. We also do work with ministers and their congregations and lay leaders. We really believe that healthier churches, healthier pastors, healthier communities, and we have that kind of reach outside the community as well. We keep trying to tell every faith community we're connected to, you're a parish church. It's not your job just to take care of the people who enter these doors as members. It's your job to help take care of the health, welfare, and help resource every person who lives in your neighborhood. It's a value that I think is taking hold and that many people are learning to appreciate because of the seeds of the work that so many have sown in our community, and we're excited about some of the results of that. One thing that developed from that was a particular focus for us in the 38109 zip code. We have some special projects there that are going on, wellness fairs, work with individual community members who were what we would call familiar faces in our system. They maybe came to the emergency room 30 or 40 times a year. That was their provider of primary care. And so to help them have better health, that cannot be the way they receive their health. They have to have primary care providers. They have to have access to the best care that we can provide. So I'm going to tell you two stories. As a preacher, I like stories. These are two stories. One I know saved a person's life, and the other one saved their quality of life. In a relationship we have with West Clinic, our partner, we do screenings, mammograms for women who've never been screened in many instances. It's in a Komen grant, so whole group of women have been screened hundreds, now thousands through this process, but one woman was screened and she had advanced what was considered a cancer that would probably take her life very quickly. And once that was identified, the West team and physicians helped provide care and treatment. We were able to have the surgical procedures and other services needed provided through Germantown Hospital. And literally, every physician said her life was saved. Her life was saved. That's the business we're in. I think that's the common business that we share, not only saving lives, but better quality of life. And then there was a young woman who had a severe kidney disease. And she was in the familiar faces list. I think she had missed 80% of her class days in school. Well, she became connected to one of our community navigators who started caring for her as a person. Started arranging for her to take her medicines, to see the appropriate specialist. So we have pictures of her transformation that she allowed us to share. So this went on for about 6 or 8 months, kind of reclaiming her life. Started to get back to school, catching up with her studies. And then we had pictures of her going to the prom last year, beautifully attired and with this huge smile on her face. And I'm happy to report today that she graduated from high school. She has a job and she has a primary care provider that she identified herself. So it's a victory when people's health is reclaimed, and that was her salvation. The other woman's salvation was her life was saved. But the good news is that these stories happen every day because of the work that's being done. But we still got to do more of it. It's got to be represented by policy changes and the care that we have for our neighbors and citizens in this community. And I've pastored the churches who are in the suburbs, and they need to be transformed too, just like all of our congregations do. So it's a joy to support and appreciate all this work that you're doing.
Great. I'll send Ken to the suburbs.
Come on, brother.
He's not busy.
Great, thank you, Harry. Your stories are great, and I think what Harry's story about the familiar faces point out, for one correction, is they actually have familiar faces who make up to 200 visits a year to the ER, which is like hard to believe. And if somebody's going to the emergency room 200 times a year, I'm willing to say that's not working. But Harry's pointing out that there's another way, and that I believe is totally in this city got to be led by the faith community. So I'm Scott Morris, and I'm a United Methodist minister. I'm a family practice physician. I spend most of my time playing doctor, but think of myself as a pastor. I'm the founder and the CEO of the Church Health Center. While Ken was at Harvard, I was actually at Yale, and he started in medical school. I started in seminary, but one day I'm in the chaplain's office at the Yale Medical School, and I look on his desk, and there's a little pamphlet that says how to start a church-based health clinic. And I go, that's it, that's what I want to do. And after finishing my training, I want to stay in the South. I don't want to go back to Atlanta where I'd grown up. And I read somewhere that Memphis was the poorest major city in America, and based on that, I said I was going to Memphis. So I came here in 1986. I was 33 years old. I was too young, too dumb to realize what I wanted to do, had no chance to succeed, and to start something that is called the Church Health Center. It has a cross in its logo that's led by a Methodist minister. I went to the most obvious place for funding, a Jewish family foundation. And it was the Plow Foundation that gave the initial dollars to start the Church Health Center, and it's reflective of everything we do. Paul said we see through a glass darkly, and that could not be more true. John Wesley, the founder of the Methodist Church, said, if your heart is like my heart, then give me your hand. And really, so the answer to my question of no to your friend and your question, and I'll talk more in a second about why this is. I mean, from hearing what everything you talked about right now, I mean, we got this thing under control and we got this solved, right? Well, no. So the number one, but what we have is amazing capacity. But what we don't have is alignment. And as Ken and I, through our thing we work together on at Healthy Shelby, most everybody here is connected in one way or the other. I mean, we have an enormous opportunity to do great things in this city. And it can't just be what the doctors do. As you've probably been beaten up with this idea of social determinants. I mean, healthcare is only 10% of anything that has to do with your health outcomes, and yet that's where all the money goes. That's where all the money goes. Now, we're spending some money on our genetic makeup, and by the time your grandchildren are grown, we will be able to create enormous anxiety in them about diseases they are predisposed to have. We will not be able to do anything about it. But we will create that anxiety. But why is it that your zip code is a far greater determinant of your health outcomes than your genetic code? That is absolutely the fact in this city, and that's where all of our efforts, in our opinion, need to go. So the Church Health Center, we currently care for over 70,000 people, all who work in low-wage jobs, and we do it without relying on government funding. There is no such thing as Obamacare. That doesn't exist. The Affordable Care Act is just a way that people can potentially be given money to buy health insurance on the open market. Since we killed Insure Tennessee, more than 90% of those 70,000 people we take care of, all who are working, they go to healthcare.gov. They make less than 138% of the poverty level, which is for a family of four, $32,000 a year, for a single person, $16,000, and they're told to go apply for Medicaid. Well, that's not an option in Tennessee. So it is hard to believe, but the poorest people get nothing. The poorest people get nothing. In Tennessee, Obamacare is a non-existent thing, for the most part. I mean, I saw a woman this morning who she's married. That marriage isn't doing very well, but she's got 3 kids. I mean, she's working 2 jobs. She goes back when you could to healthcare.gov. Still going to cost her $150 a month. You don't have $150 of disposable income to buy a policy that has a $5,000 deductible. Now, would you buy that policy if you are struggling to make ends meet and it's going to cost you an extra $150 a month? Would you spend that money? That was her decision, and she, I think, rightly said no. So how do we move forward? I think it's about working together. So my one story is the Church Health Center currently operates in 14 buildings. It's unbelievably inefficient. We're moving our entire operation to the new Crosstown development, which is called Crosstown Commons. We're dropping the Sears. Quit saying Sears Crosstown. It is Crosstown Commons. There are 16 entities working together here, built around health, education, and the arts. Just a couple of examples of people who are going to be there and how this is going to make a huge difference in this city. Bring It Food Hub. I mean, I'm out of the food business now. I don't know anything about food. I eat it. I know how to tell people what to eat, but we're not in the food production business. So we've now formed a partnership with Bring It Food Hub. If you're not familiar with them, go to their website, and then you need to be buying food from them because it will give you, during the summer, weekly food, locally grown, make you healthier. And then the money you pay will allow us to provide food for poor people in the inner city. And without any charitable dollars. It's an incredible model, and so that's our partner. There will be a charter school run by Goodwill for adults. Why does that matter? Because why do people drop out of high school? A young girl gets pregnant, and you can figure out the rest of the story. So by going to this charter school, you have to be over 18 years of age. It's going to be funded the way charter schools are funded. But what we fully know is that when she graduates, she will make $10,000 more than she's currently making and almost certainly have a job that offers her health insurance. So when I see her, once we get to Crosstown, I can take her by the hand, walk her down the aisle, and roll her into this high school knowing she can graduate in 18 months. That is a better mousetrap. And then the magic 270 apartments in the top floors intentionally designed for young doctors, young artists, young educators, and I'm hoping young lawyers. Anybody who wants to help us figure out a way to have young lawyers live in this building, come talk to me. Thank you.
We've got about 20 minutes. I get to ask these folks questions all the time. So I'm hoping you have some questions you want to ask them. If you do, just direct your question to a particular person or to the entire panel. We're going to let everybody weigh in on it if they want to. Does anybody have a question? Yeah. Could you say just a little more about what you mean by traditional versus?
Traditional versus modern.
Yeah.
Traditional, that like biblical terms of what's valued in the family and the community versus modern day, what's happening in the community. So, when it comes to having people that are colleges, they might have very big issues in the programs. So, that one of the very differences is based kind of common or just how do you basically.
Well, one of the nice things about all of us here is that we're all rooted in the Judeo-Christian community, and we can probably speak at least from that perspective uniformly. And one single theme that I can say to my congregation is that God wants us to live. And that's a very simple but very profound concept. It's rooted in Hebrew Scripture. It's rooted in the Christian New Testament. The concepts of salvation can be translated in Hebrew and Greek as health. And so when you really look, so in many instances, it's not so much about traditional versus modern, but it's about teaching and awareness of what that means. It has meant different things at different points in human history. Today, you've articulated some issues, and Pastor Norman has talked about how they have ministered in very specific ways to a community that has been misunderstood. I would say Scripture has been misapplied, misinterpreted. But if you think about God wanting us to live, that is timeless. It transcends denomination. It transcends multiple world religions. It is consistent with all that we stand for. And our challenge is just to translate that into ways that more modern, contemporary audiences and more traditional audiences both understand and find common ground.
But I think Ken's totally right. And the point that Keith lays out in his church, I mean, he was the first person to step up to take the HIV test. Well, what does that mean? I mean, if you're talking about HIV in a church, we're talking about drug addiction and sex. We don't do very well talking about that in churches because nobody in a church has anything to do with either one of those things.
Exactly. Ken's a lot nicer than me. I keep a short list of churches that they can join. Tell them you might want to go here because these are the things we are going to do. And this is what we're going to be about, loving all people, seeing the image and likeness of God, the Imago Dei, the Imago Christi, and all people. And so no matter what their walk of life is, we're going to embrace them here. We're going to love them with the love of God. Now, if that means we're going to provide services in health care, we're going to do it for everybody. We're going to love and care for all people. Now, if you have a problem with me loving someone because of your views and your values that are age-old and antiquity, then I can't change that. And it might just get in the way of me doing what I need to do for this person. And so I don't have a lot of time to help. If you want to hang around and give them time to, give your values time to change, then stay here and watch, but don't get in the way of the work. And if you want to get in the way of the work, I send you to Ken's church. I said, it's a short list. Go over here and they got to.
Gee, thanks.
I dropped the bus off last week.
No, I got them.
This may not be an exact response to your question, but at MIFA, because we are interfaith, we strive to bring people from different faith traditions together to serve, because as you were saying, one thing all religions have in common, and we believe one thing all faiths have in common is the wish to serve and take care of those who are in need. So we'll often have interfaith activities where it's youth from the Hebrew school and youth from the Memphis Islamic Center coming together to do things, and I think activities such as that at least help bridge differences and approaches.
I'd just like to add a quick word that builds on this. John 10:10 says, Jesus says, I have come that you might have life and have it abundantly. Not just life, but quality of life, and have kind of the richness of life that God offers to all of his children. Knowing these folks here, I think everyone has what I would call an ecumenical soul. I mean, they value every tradition, and we respect folks who have no tradition. I think some studies show the largest growing group, if you put people in groups, are the nuns, those who will not identify a particular faith tradition. So we care about them as neighbor, and that's a part of our charge, to love God and neighbor. And I think that if we're not able to make that shift in today's culture, then we're going to miss our ministry.
And I'll just jump in quickly just to add from a Jewish perspective. Of course, our Hebrew Bible talks about choose life so that you may live, as has been mentioned, and there are plenty of places in Jewish liturgy. But also, we also have the case of Dr. rabbis such as Maimonides, the philosopher Maimonides, who is a rabbi and also a physician, and who's done a lot of writing about concrete how we must care for the body, no matter what. And also a lot of later writing during the Hasidic period that talks about how the body has now become the temple. After the destruction of the temple, the body and the self has become the new temple that we must take care of. And of course, as has been mentioned, that all humans are created in the divine image. When you're talking about more progressive Jewish communities, they don't really have an issue with that, and they roll along. When you're talking about more fundamentalist Orthodox communities, these are the kinds of things that are going to come up that people will use in order to work together.
It's a great question. Who's next? Yes?
So obviously all of you are at the top of the heap when it comes to this interfaith and health work in our community. And I guess as Memphians, just in sheer numbers, we know that the faith-based community is so large here. So I guess my question is, like, if every church in Memphis is doing the same kind of work that you all are doing, then I guess a lot of our problems could be solved. So I just wanted to ask about the Congregational Health Network. I mean, do you see that as a vehicle to get your work or your message, or even to inspire other congregations to engage in the same kind of thing that you are?
Yes.
That's your question, obviously.
I mean, I think a goal would be to inspire other congregations, but we know we only touch, even in those 580 congregations, and that's greater Memphis, some congregations in Mississippi and some in Arkansas, that only, begins to touch the rich life of the faith communities in Memphis. So there's a tremendous amount of work to be done. And when I say 580 congregations that we're in relationship with, they're probably about half of those who are really active and committed to the values that we're trying to practice and teach about good health and how you connect health and faith. So there's an amazing amount of work left to be done, and it only just briefly touches the beginning of the issue that has to be addressed. And even if you put all of our work together, I don't know, I think there are 2,000 congregations in the greater.
At least
is it almost 4,000?
And counting.
There's 2,000 on my street.
I know that's
right. So, I give it was in the thousands. I've heard estimates of 2,000 to 4,000, so there's much work left to do.
I mean, our biggest problem is that while we would all agree there's a link between faith and health and your body and your spirit, that is absolutely not universal.
Right.
An example of that I always give is in the midst of the obesity epidemic in America, clergy are 20% heavier than the rest of the population. We have blessed the sin of gluttony for the sake of fellowship, and it's all about the Spirit to convince people that the body is part of God's creation. That is difficult on both sides of the street. It's hard to convince the doctors that there's a spiritual dimension to life. It is equally hard to convince the clergy that they should care about the body, but you can't have a healthy congregation if you don't have healthy leaders. And trying to get people to preach this from the pulpit, it's not just about AIDS, it's about, how do you solve this food issue? If this is not a church and faith community issue, I don't know one, but we don't quite know how to do it in our own backyard.
And I want to just address the issue of scale, and because it may sound and seem as if we are all at the top of the heap also in terms of relatively large congregations, but what I was talking about around addressing social determinants of health can be done at any scale, and I suggest and advise and counsel pastors of smaller churches, do something. So that an after-school program with a couple of volunteers that helps a young person do better, perform better, improve their academic performance, might keep them in school so that they'll get the high school diploma, that immediately they'll have higher earning potential, changes trajectory of that individual, the individual's family, and the income potential for that family, and guess what? Makes them healthier as a family. So it is a social determinant. Little things can be done, and so I'm certainly not wanting to suggest that it needs to be done at the scale that some of us have been blessed to do, with a lot of partners, by the way, including the folks sitting at this table. So the issue becomes doing something, right. and helping a couple understand that saving will increase their capacity to have a little something. They might be able to even put a little down payment on a house, and suddenly there's equity, and that's a wealth builder and capacity. So anything that at any level, any congregation might do to actualize that concept, that it is about spirit and soul. Jesus said, I pray that your whole spirit and soul and body be preserved blameless. So it's a very holistic approach, and I didn't want to suggest that it needs to be done at this level.
Well, can I just speak to that for just a second? And when I said top of the heap, I meant just your credentials.
Yeah, I'm in good company.
Thank you.
I'd also like to just jump in quickly. One of the things that we're going to be doing at Beth Shalom at our synagogue in a couple of weeks, we're going to be starting at the holiday of Passover a program called Healthy Body, Mind, and Spirit. It's going to be running through the 49 days of the Omer period. That's between the holidays of Passover and Shavuot. And so that's April to May. And we're going to be offering a challenge for our congregants and anybody else in the community who wants to join us of various events that we're going to be offering. That will be cooking classes and all kinds of things about talks about health in Jewish history, walking, exercise, spirituality, a whole range of things. And culminating in the holiday of Shavuot, we're going to have everybody who participated there gather together and talk about what it was that they learned by taking on this particular challenge for those 49 days.
There was a question over here. Yeah.
I guess I'd be interested to know what the faith-based community is doing along with the healthcare provider and business community in terms of Medicaid expansion, especially with regard to the Church Health Center, how much the lack of Medicaid expansion might affect that moving forward. I know it's been around a while, the problem's been around a while, but it seems to be growing. But it was surprising, I think, to most people, the really unprecedented support from Sure Tennessee, and then just a few legislators were able to do it. And so I know there's a push to revitalize the reintroduce the plan or something like that for the faith-based.
Yeah, so I'll just give you. There's only one state in the South that has expanded Medicaid, and that would be Arkansas. So how is it that if you were born on the left bank of the Mississippi River, just right over there, you're poor, you get health care? You're born on the East Bank, right here. You don't? So is that a political problem, or is that a moral problem? Now, there's been an enormous amount of political angst around the issue, but the faith community has been unbelievably quiet, in my opinion. So it is frustrating at some level, but from the Church Health Center standpoint, Jesus said the poor will always be with you, and so far he's been right. So even had we been able to implement Insured Tennessee, I promise you, the Church Health Center is not going away. That's why we're moving to Crosstown, and we're growing in dramatic ways. That there are a lot of things that the Affordable Care Act doesn't even touch on. In 2,500 pages of the law, the words adult dentistry do not appear, not in there. We consider dentistry to be an economic issue. You can't go from a $7 an hour job to a $10 an hour job if your teeth are all messed up. Not going to happen. And politically, on the left and the right, we've thrown the immigrants under the bus. You've been building houses in Germantown for 20 years, and you fall off and you break your arm, and you happen to be undocumented. Nobody cares. Nobody cares. I mean, that's the issue I'll lay down the street over. At the end of the time, I got to look Jesus in the face and be asked, what did you do when that person came to you? I want to say I did the best I could. So, for as far as the Church Health Center is concerned, we have to grow and do what we're going to do no matter what. Now, and I'm going to shut up and let others answer here, but the problem with the Affordable Care Act is that if you support the president, then everything about the Affordable Care Act must be something really good. If you oppose the president, then everything about the Affordable Care Act must be really bad. And the truth is somewhere in the middle. There has to be a middle ground, but from a preacher standpoint, you're worried you're going to offend half your congregation no matter what you say. So I'll let the other preachers who have to deal with that speak more than I can, but it's hard.
I found myself in an interesting position on this particular issue because while on one side I was fighting for it as Vice President of Government Affairs for Baptists and lobbying, trying to make sure that it was passed, getting the information out to congregations and educating pastors was a difficult role, especially in the midst of so much misinformation and such a heavy political environment where there were millions invested to keep the misinformation going and going and going. And so pastors and churches not always having the capacity that we have and having full-time staff, leaders, and people who are available. Many pastors didn't know how to deal with the issues, such as not knowing really how to deal with the third component, which is an equitable component of the ministry of Christ, preaching, teaching, and healing. We get heavily involved in the preaching and teaching, but how do you deal with this healing piece in a modern age? And what emphasis should be placed on it is often the great question in pulpits and across America, not just here in the South. I find it more concentrated here. Other places deal with it on a larger scale and a better scale, but here it seems to be somewhat of a question mark of what engagement point. And then if you politicize the issue, you start getting into the issue of, am I supposed to be in the political arena? Well, I've often told people this whole idea of separation of church and state is crazy. If you read the Bible very carefully, it was always the priest that was informing, or the priest and the prophet that was always talking to the king and giving information. The David and Nathan relationship, the Ahab and Elijah relationship, you name them, all throughout the scripture you find them there. So we should be involved in the issues.
So, at the sake of being redundant, God wants us to live, and for the sake of this symposium today, this is a classic example of juxtaposition between health, law, and policy. And for those of us, including myself, that have served in governmental positions, this is extraordinarily disappointing. The failure of Insured Tennessee, and prior to that, the failure of our state to expand Medicaid. It should be non-controversial, and I would suggest to you that even as recently as my tenure as commissioner in 2007, this would have passed the Tennessee State Legislature. At the time, public health was considered to be a public and governmental function. There were fiscal arguments that carried the day. Legislators who really had no constituency in large urban communities still understood that it would save the state money to be able to expand certain offerings in the classic TennCare program. This would have been a no-brainer. So the world has changed, and it is extraordinarily disappointing. On a good note, I would say that you have present at this table persons who have sought to stand in the gap, be the repairer of the breach in very, very different kinds of ways, but understand these are literally stop-gap approaches. He's got a federally qualified health center on his property. Scott Morris has the penultimate example of a faith-based provision of care for the working poor. I just try to run my mouth. I'm a talking head, public policy kind of guy that we've been sort of advocating and working politically. Everybody was aligned in this state around this issue. All the CEOs of our faith-based hospitals, of which we have 3 major hospital systems in this community, corporate CEO, everybody. So I hope you do take this home, that this is disappointing. And when people talk about the fact that in this nation we don't vote, and we do not vote with our passions around the things that we, as people of faith, have driven us to support, it is entirely disappointing.
Can I get an amen? Yeah, okay.
No, there's a hand over there.
Oh, sorry.
No, I don't get to ask questions. I'm up
Last
here.
question.
Question is for Scott, with the Church of Health Center. You mentioned the Crosstown Concourse. Now, that's a major project.
Very good. Crosstown Concourse, very good.
Major project in the community with a lot of health disparities. So what are you all doing to ensure that those within the community are aware of the programs you offer and have access to the services? And how are you leveraging those resources that can be found in the community?
Did I pay you to ask that question? All right, so let's start with, the name of the neighborhood is Crosstown. That is about transportation. It remains the easiest place in Memphis to get to if you are poor, from a bus line, from every other thing you can imagine. Number 2, you could argue that the neighborhood just north of us, which is where our preschool is, where Keith's wife is the principal, is the poorest neighborhood in America. I can show you the numbers to prove that. This project in no way, shape, or form is about gentrification. This is about the community, and it is the reason I care so much about the apartments that I mentioned where I want young lawyers being there. This is about the brain drain in Memphis. It's about the young future of Memphis. Have people there solving the very problems we're talking about. So we will, not only will the Church Health Center, we're moving out, we're putting all our marbles in this basket, but there are 16 other entities there, including economic, I can't give the name right now, but a bank entity, sort of what Ken was referring to about your first loan, a charter school for adults, another charter school. This is all about that neighborhood just north of us, not displacing them, but to be able to give them the opportunity to succeed. If we fail on that, I need you to tie me up and throw me off the bridge. Unfortunately, it'll be a while, but then I'll probably be too old and then won't care at that point. But
Well, as you all heard for over the past hour, we are indeed blessed in Memphis to have these folks here with us and doing our work for us. Please thank everybody. Thanks for coming.
It makes me think of a joke. So a reverend, a rabbi, a reporter walk into a bar. I bring it down. I'll bring it all down.
I thought you were telling us what bar to go to. I was going to say, where are we going? That's what I was listening.
Give me an hour and a half. We have a break now until 2:30, and then we'll have our final panel talking about building on this great atmosphere that we have. What local assets do we have going on, and how can we leverage those? So I'll be back here at 2:30, and we're for our final panel. You're in the home stretch. The bar is coming.
Yeah, no one, I didn't see it.
Yes, yes, and you just.
Thank you. I just didn't see it. Thank you. Thank you. Love you. And I can't, obviously, I don't respond time. We from Maryland.
Thank you. You got it. Good to see you. Linda, did you say my Yes, I did. I did. Thank you. Thank you. Yeah, we got it together. I talked to I'm there with a dinner, and I thought it's funny that they put us both such a wonderful experience. I'm glad you were in Nicaragua, but yeah, that's right. I was there. Oh, really? Was that recent? Yeah, there. Yeah, it was just in February. Oh, God. Okay. It was. She did. Linda started off and just. Yeah. Thank you for asking. We support John. I know. So you two ladies, I have something that I need to really be about to talk to you about. Hey, and so we'll get together later. Okay? Okay? See that? If I call my show,
Should I ask? I have a thumb drive. Should I give that to you?
It's loaded right here is
I would love it.
I'm so excited about that.
So I'm just going to talk about our CHAMP program. Very good. You'll come back with city government. Because I think these are we need some addition was pretty close. You know, and that's and we can't do it alone because we can cite the owners, but that gets one solution. It doesn't create a solution for a whole housing development. And just because there's nobody living in a particular unit with a child now, doesn't mean that next month that's not going to be a change. And it's really, it's a waste of resources to have you come back here.
I'll make you feel better. I'll make you feel better.
It is.
Exactly. Fake it till you make it. Isn't that right? It's a lifelong process. One of his comments
Thanks, I put your parking permit there.
Water. Nice to meet you. Yes, sir. You got time over for...
Good, how are you?
Is anybody
No, she don't copy the executive session. Yeah.
I haven't seen any difference.
So,
Always
this is the executive session.
there are times that same approach. Writing the book as we go. So no, I think we just can go about those differently. And but I think we're looking at the same thing. In the city. And you've always been that way down. I am I've always, I get it.
I guess so. I guess we're going up in one. So, I'm, probably go to that thing. This is my last slide.
Yeah, that's what
What I do is,
so we have 15 minutes to share, right?
Honestly, I think you're, and I'm just going to
So I no longer go to the Y downtown, and she now goes to the Clark Center. So we have all, changed places. I know for 15 years we'd see each other come and go. So where's your office?
I'm right at Lamar, so across the street from the hospital.
Oh, you are in?
Yeah,
Okay.
actually across the street from the hospital, but we have a community outreach. Yeah, in the same building as them.
Okay.
But we have another community outreach department right here at 50 Peabody.
Yes. Okay.
So I'm under that umbrella, but I'm physically stationed.
On the north side of it? Okay. My daughter's a child life specialist over in Lamont. Abby Shipman. Abby Cooley. She's shorter than I am, but they say she looks an awful lot like me. Okay.
Because we coordinate with Child Life a lot because we use the room of magic, the theater room that they manage.
She's right now her assignments. So she will get asthmatic children. She'll get children with diabetes. She'll get children with all kinds of issues. So, what's your background? My background is actually adult education.
But I've been in community
Adult education.
Adult education. I started out in community education. I was going to training child care providers on prevention, and then just kind of transition there to data analysis.
Wow, Champion Bridge. That's really pretty impressive. Please. So, hi, Janet Schumann, nice to see you again. Nice to meet you. Now, there's another John who John Z. Can you get ready? Yeah, John Z. And so, I had to think for him. Hanging in there for our last session.
Is this one your water?
That is.
Again, as last time, I have the easy job of just turning it over to our fearless moderator, who's actually now doing my computer read. We've all discovered so far how bad I am at technology. But our last panel, again, is keeping in the theme of talking about, sure, we have challenges, but the opportunities that exist and the things that we can leverage in Memphis, and how can we do more about connecting the good things happening. I wanted us to end with hearing about some really exciting things that may not on their face seem like health or like policy, but how they actually tie in quite intimately to what we're talking about. We'll hear about that. We'll have an opportunity for questions, and then we'll wrap it up, and we'll let you get out of here. So I turn it over to Steve Barlow.
Hey, good afternoon, everybody. I'm Steve Barlow. I'm a staff attorney at the City of Memphis, and I have a private law practice in which I focus a lot of my attention on addressing blighted properties in the City of Memphis. I've joined one of the professors in the room, Danny Shatson, in a first of its kind law clinic where we take 8 third-year law students into Judge Potter's courtroom. We used this particular conference room as an impromptu courtroom a few minutes ago and got a receivership order entered. So everybody can breathe easily. We have a house in the Evergreen Historic District, which will start to be rehabbed by a third-party receiver on Monday. Anyway, this is a group of friends. For me, I'm so honored to be here today. I'm not going to say much, I promise, because these folks each have a lot to say. In the way of introduction, though, I want to do this a little bit differently than maybe you usually do your introductions. I don't want to read you any long list of names, and I want each person to have a chance to say what they want to hear, what they want you to hear about them. But first, I want to know if anybody in the room can guess which one of the people on the panel was a poli-sci major in undergraduate. Okay, raise your hands, anybody? Anybody want to make a guess? Anybody know? All right, well, go ahead. Emily?
My major was TV and radio.
All right, well, the winner of poli-sci major, please stand up.
I'm guessing that's me.
All right. There's one person who won the distinction of Young Professional of the Year very recently. Can anybody guess who that would be? Don't rule out Judge Potter. Anybody want to guess? Oh, that was a...
I just look really youthful, right?
Yeah, we shouldn't have ruled out Otis on that either. How about a former hazardous materials specialist? This is a pretty interesting one to me. Janet.
No.
We have a guess for Janet. Anybody else? Oh, now we got it. Mr. Tidwell is the former hazardous materials specialist. Okay, this person is either blessed or cursed, like I am, to be a government lawyer. Anybody guess who that would be?
That's easy.
I'm sure there's something. Tell us something really exciting about yourself, Janet, so that we won't just leave it.
I've done 5 marathons, and so it's been a little while, but I either walk or run 3 times a week. So.
All right, good, thank you.
And I am a grandmother. So.
Who can guess, or maybe somebody in the room knows, which of the panelists lives in a converted firehouse?
Oh.
He's a big buddy, so that doesn't count. I'm sure it is. Just ask him.
Depends on which code.
Don't ask code, ask Tommy. Let's see. Judge Potter, would you like to say a few words about yourself?
Oh, gosh, no.
Judge Potter is one of our community treasures. I wanted to save a little bit of an introduction for him. He founded the nation's first environmental court. It's been in operation for 30 years. A lot of our, that's my signal to stop. It's a very annoying sound, but she makes stop. I want each person to say 1 or 2 things about themselves that they want you to hear, and then we're going to get started with Judge Potter on presentation of some creative uses of law in health and policy.
Actually, I am an ex-teacher, school principal, worked for state government. Worked for other areas before I went on the bench. A private practitioner, a public defender, prosecutor, and city attorney.
You've done a lot.
I've had trouble keeping a job.
Tommy, do you want to say a word or 2?
Sure, I guess. I am an alumni of this law school, but not of this building. So that kind of, I guess, dates me a little bit. Well, I'm still licensed as an attorney. I haven't really practiced the dark arts since 2009-ish. So I still keep my license active, but I've primarily been doing city planning work and community development work.
Thanks. Christina?
Sure. I actually have a background in journalism and adult education. I've been in the public health arena for the past 7 years. I really enjoy it, and I have a passion for patient and family-centered care.
Thank you. Otis, you want to say a word?
Yes. I'm a minister. I do outreach ministry. Left for a thriving ministry up in Rossville to come back to the inner city. And I love to cook. So when I'm preparing my message for Sunday morning, I get in the kitchen and cook. And sometimes I make my wife real mad.
I bet sometimes you make her happy.
Oh, yeah.
I'm a graduate of the University of Memphis Law School, and sorry to say I wasn't in this building. I sure wish I had been, but I'm also a journalism graduate from the University of Missouri. And I was a prosecutor for about 20 years before I came into doing healthcare law. And during the past 10 years, I've had the privilege of developing the job myself at the Shelby County Health Department. And so it's been a true revelation, but it's been a fabulous career. And it's one that I hope that other health departments and cities will replicate across the country, is to have an in-house health department lawyer.
Great, thanks. You want to say a few words, John?
Sure. I'm also a graduate of the University of Memphis, but in city and regional planning. I've been a city planner in the city of Memphis for about 11 or 12 years now. Currently serve as the administrator for the Memphis and Shelby County Office of Sustainability, and just completed management of the Mid-South Regional Green Plan, which is a regional plan to connect a network of green space across the tri-state area.
Thanks, John. Emily, last but not least.
Hi, I'm Emily Trenum with Community Development Council, which includes the Livable Memphis program. And I also am a planner. I had a whole first career in corporate marketing and communications, and then went to planning school here in Memphis, was world's oldest graduate student, felt like it anyway, and now went from that to working in community development, and it's been very rewarding.
Thank you. Well, we have it broken down into 3 groups today, as you'll see in the agenda. The first couple of folks are going to focus more on the using the law in community development and health. That's Judge Potter and Tommy Pacello. The second group is going to talk more about policy and codes and the involvement of those in a healthy homes agenda. And then the last group is our comprehensive planning and how health relates to the comprehensive planning. So I am ready now to hand it over to Judge Potter, and we're going to try to reserve a little bit of time at the end of each group for some questions. Get out of your right, dude. Thank you, Judge.
You're never in my way.
I believe you're ready.
It is an honor and a pleasure to be here. I am also a graduate of this law school. Last century I graduated from the law school. Not in this building, not even in this century. Disgusting. But I'm happy to be here. We have been working with the Shelby County Environmental Court since 1991. We started the Environmental Court in 1982, before most of you were ever born. Looking out and seeing some people have the same color of hair that I do, that's not true. But time is short. I've been told I have 8 minutes. You notice what Steve Barlow has that will go off. I told him he wouldn't have to worry about that. He said, please let me one time tell you to quit talking. So I may give him the chance, Professor. I think the time has come for him to give me the chance to quieten down. We started this court in 1982, and I don't have time to go into the reasons. I'd love to give you the details as to why we started this court. We started this court, just a little snippet, because there was a need. There were people who were not being dealt with by the court system at the time. It wasn't the fault of the judges. It was the fault of my computer. Let's see. Am I doing it upside down?
Oh,
don't count this time against me, Steve.
Pause. Pause.
All right, there it is.
Oh, didn't go on this.
What happened? What we have here is a failure in which to communicate. There were some really great dirty pictures for you guys to see. I'm really disappointed. Bottom line is this. There were blighted properties that people were going to court with, and they were in the inner city, and those cases were being dismissed. The judges felt as if those cases were not important. They were more concerned about criminal cases. They were more concerned about... You promise it'll work? No promise. I won't hold you in contempt. These are the type of cases that we saw. And actually what we saw in 1982 was not this bad. It has progressed. The problem in the city of Memphis has progressed. I have been preaching for over 30 years that there is a direct correlation between blight and crime. If you deal with the blight, you deal with the crime. And it's taken 30 years to get people to buy into this concept. We actually proved it in Hickory Hill. with a community court where one of the police precincts, they wrote these cases in great numbers. They reduced crime by 22%. And it works. If you go in and have zero tolerance, or if you go in and have a low tolerance for blight, you're going to have reduced crime. These are problem properties. There are thousands of properties just like this. I know I'm looking at this and, oh well. There are problem properties all across the county that look just like this. By the way, this property is no longer standing. It has been demolished. What bothers me is there are many problem properties that probably should not be torn down. But there may not be a quick solution. And if you don't have a quick solution, that problem property is going to stand in the community. Children walked by their way to school every morning past this. There were drug sellers in this property. There were prostitutes in this property. There were people who were not exactly very nice in this property. Those were just some of the nicer ones in the property. And we were concerned about their safety. I'm joking, of course. We were concerned about their safety. That had to come down. I have other photographs, but the point of it is this. We've been writing laws, I have, along with other individuals, for years to deal with this problem. We now have some very strong laws in the state of Tennessee and in Memphis and Shelby County to deal with the type of problems that you see here, or was going to see here. And this is not the fault of these guys. You've got to understand, technology never works for me. There's a little cloud following me, and it's called technology that doesn't work. This has been torn down. This is in the process of, we hope, being renovated. Note that there's a church here next to this. This is Wooddale Condominiums out on Winchester. I know you're getting ready to beat me out, but can we go on to the next one? Maybe. You might have to do it manually. This is another one that is showing on the screen there, but it's not showing up there, that also has been torn down. And this is thanks to Steve Barlow, and thanks to Mr. Tidwell, and thanks to the city of Memphis. There it is. That one has also been torn down. It was across the street from the other one that I said has been torn down. And these are two houses. A child died in that fire. A lawsuit has ensued, and the owner has gone into bankruptcy. That one is an old photograph that I hope that one just collapsed. That's an old photograph that we had to show you. But it's very normal to what we see in the city of Memphis. One more, maybe. That's... and maybe one more, yes, after that. All right, now look. We're starting to put up cameras. Mr. Tidwell and his people are starting to put cameras up. We get tires. I lose sleep at night dreaming about tires. Tires. What do you do with them? It's a great question. Hopefully you don't dump them illegally. That's what we see. Last one. Well, maybe there's one more. Was leading environmental court. My referee's son looked at this and said, "Daddy, why is he so mad?" You'd be mad too if you knew what I was standing in. That's the environmental court. We're there because the city has problems. I want to thank those of you who are at this table. Most of you come into that court. I want to thank those of you who are not familiar with it, those who are. We work very hard, very diligently, and the people of this city and county have been wonderful. We are the national role model for environmental courts in the United States. Memphis is first. I'm very proud of it. Thank you.
Keep rolling.
Yeah. Well, now that we've tried out the technology on the judge, let's watch it work smoothly.
It'll work smoothly for Tommy, yes.
Thank you so much, Judge. And after Tommy's finished, we'll take questions for a few minutes from either Tommy or Judge Potter from the folks who are here.
And then I can just use the
I didn't get to hear my ship siren on Judge Potter. I'm disappointed.
You had the chance.
All right, I think it's going to fly. Let's see.
That's disgusting.
I'm here to meet you.
Thanks. That's a really tough act to follow. I've got a great deal of respect for Judge Potter. When I was in law school, I spent quite a bit of time with him, learning the ropes of how to be a lawyer in Memphis. And what Amy and Steve asked me to talk a little bit about today is our team's work. I work for the Innovation Delivery Team here in Memphis. We are a small nonprofit that is funded originally by Bloomberg Philanthropies. And so Mayor Bloomberg, right, has a real passion for cities. And to sort of explore that, he identified these 5 cities around the country to set up these innovation teams. And using sort of private dollars, or the grant from him, the charge was to really prototype and test ideas that cities, to address challenges that cities were facing. And in Memphis, there's a whole slew of them that we could have been looking at. The first 2 that Mayor Warden asked us to look at was generating neighborhood economic vitality, and then this question of how do we look at reducing youth gun violence. And so most of the stuff I'm going to talk about today is really some of the outgrowth from our neighborhood economic vitality work. But since then, since those first 2 projects we started looking into, we've since expanded this to look at customer service in local government, like how do we fill potholes in a more effective manner. This is a pretty timely issue right now. Things like how do we increase the live release rate at the animal shelter, some of those types of projects, and also doing some work right now around transportation and mobility issues. But I think that before I kind of get into this, I think it's important to talk a little bit about the why. Like, why did we end up with this issue of blight in Memphis? And what you see here, this is a map of Shelby County in 1960. There's a little red line you'll see sort of around the kind of core of the city. That's the city of Memphis boundaries in 1960. And then each of those black dots that you see represents about 25 people. That's kind of where we lived in 1960. We're pretty tucked in close to the core. In 1970, we looked a little bit like this. A little bit of kind of sprawl happening. 1980, 1990, 2000, and then 2010. Now, the troubling thing about these maps is that there's not really any new dots in this one, right? Between 1970 and 2010, we had a 4% population growth in the city of Memphis, but we had a 55% increase in our geographic area. So, what does that mean? Like, that sounds kind of like it's out of balance a little bit, right? So, as we were shifting to the edge, that meant new roads, new schools, new sewers, that we were spending our resources on investing at the edge of the city while we were really disinvesting in the core. As well, people were shifting from the core of the city to the edge, leaving behind them a lot of vacant buildings, a lot of vacant lots, and kind of the decay that occurred after that. So that then says, well, where's the blight? Right? So one of our team's first, sort of one of our most recent projects actually, was looking at how do you identify this 320 square miles that we have in the city of Memphis today, just about 2.5 times the size of the city of Detroit. And how do you understand sort of what the damage of that was? Well, there's 2 ways you could do that, right? One would be to get in a car with a piece of paper and drive every street in the city of Memphis and take a survey of the blighted property, condition of the properties. But there's got to be a better way that's really labor intensive. So we worked with the University of Chicago and their program, the Data Science for Social Good, to use the data that the city is already collecting to then try to weight that in what they call predictive analytics. Predict the likelihood that any given property within the city of Memphis is blighted. And so, there's a whole lot of
they talk about regression analysis and random forest generators and things like that I'm not going to get into because I don't understand it. But this is sort of the result, right? You begin to see this heat intensity, and you update the data by year, and you can see how neighborhoods have progressed and become blighted. This is a web app that anybody can access, and if you later on, I can give you the web address for it. So that's a little bit about some of the data that we've been using, and what's our time?
4 minutes.
Okay. So a couple of other ideas these are just more of the programs that we've been testing in some neighborhoods. One is this idea of neighborhood retail strategy, right? As a city, we haven't done a lot really intentionally around neighborhood scale retail. Like we've had more of a laissez-faire approach. So we've been, we worked with Community Lift and others around this idea of neighborhood retail strategy and thinking about how do you help the mom and pop retailers actually perform better in those neighborhoods. And one of the things that meant was investing in those shop fronts. So what you'll see here is a program that was developed with Community Lift and with Edge called the ICE program, which has just finished its first phase. And it's amazing what a $25,000 forgivable loan can do to properties with new paint, new windows, new signage, etc. MIM Shop is another program that we worked on a little bit where we take underused vacant retail space, are able to offer entrepreneurs that are looking to open businesses within the neighborhoods to come in and open shop. And they get about $12,000 is what the value of the program is to them. So they get reduced rent and a lot of technical assistance in getting started. But more importantly, this sort of small investment in the business helps to transform some of the commercial spaces. So for instance, this is one of the shop fronts that was a MIM shop front. So they're kind of scary places when they first get going. But with about $1,500 and tenant improvement dollars and a lot of sweat equity, you end up with a space that looks like this, right? And then it becomes actually an asset to the neighborhood. The last little project I'm going to talk about really quickly was the historic Tennessee Brewery. This is a project we worked on with a whole big, wide range of people. But in essence, about a year ago, the owners of this building couldn't quite figure out what to do with it. And they announced they were going to tear it down if a new owner couldn't be found. So, and to sort of avoid that, I mean, we viewed this as not only a neighborhood treasure, but really a city treasure. It's absolutely the most seductive building in the city of Memphis. And a lot of people had tried to figure out how to make it work. But you have a lot of old buildings that are a little bit difficult to rehab, a little bit difficult to repurpose. And one option would be to tear them down, but you don't want to tear something like this down. So how do you figure out how to repurpose it? And I mean, this is what some of the proposals had been for it, and I don't know what you think of that, but one of the thoughts were that one of our take on it was, well, let's test some ideas in it and sort of demonstrate what the potential is of the building. So this idea of pre-vitalization, before you revitalize, maybe you should pre-vitalize and just demonstrate what it could be. And so Tennessee Brewery Untapped was an event about a year ago now, and the whole concept was to untap the potential of this building. And so it's community planned. The Memphis Regional Design Center drew up some plans for how the space can be reused. The residents from the area and from our city came out and helped clean up over 4 weekends and built out the space. And you can file this under it's amazing what string lights and beer can do to it became like it's a really great community gathering place, right? And again, the whole purpose was to show that you could cash flow this property. And here's a legal issue that sort of walks that fine line, I guess, about whether you ask permission or just kind of set up a pop-up trolley stop. Activated with community resources, measured everything that we did. And then you had $20,000 investment over a 6-week period that then generated $325,000 in sales. Again, making the point that this property could cash flow and that you didn't need to tear it down. And then for us, we thought it was important that it changed this conversation about historic preservation in Memphis, but then more importantly, Billy Orgel was able to sort of see the value of this and stepped in, bought the building, and is rehabbing now. So anyway, that's all I've got for you. Thanks a lot.
I think you can see we have a tough job here today. We have each one of these folks on the panel can spend a very long time, which was great. Who in the room visited the brewery
open last summer. Yeah, I think we probably had a lot of Does anybody have any questions for Judge Potter or Tommy Pacello? I'd like to give you an opportunity now. Go ahead.
Judge and Tommy, in talking with the both of you with students, one thing that stuck out to me was some statistics. Tommy, I think you may have shared, and Judge, I know we've talked about it, about the impact on blighted properties just on community morale and on the individual morale of adults and children. Tommy, I can't remember, but I'm thinking, I could be wrong here, that you shared with us some statistics about how common it might be for a child to walk by a blighted property on the way to school. And even if you don't have exact statistics, that really resonated with me in terms of, we talked about environmental stressors this morning, that kind of thing. Can you just talk a little bit about that? And Judge, anything you can share about just the impact? Because I know you're a big believer in trying to keep structures up, not knocking them down.
Right.
Building communities that way.
You want to go first?
Well, he's probably got statistics. The statistics that I have are somewhat dated because of what happened in 2008, 2009 with the downturn in the economy. People just walked away from their homes, and what you have with blight is it destroys neighborhoods. And you can go back to the photographs that he had showing the city and the county, and you can just zero in on the city of Memphis, and there's a tremendous number of not just blighted neighborhoods. And there are wonderful people that live in those neighborhoods, and they want something done for and to their neighborhood, and they deserve it. And that's what we've tried to focus upon for 30 plus years, is really the inner city. And that is also now moved out to Frazier. We're starting to have problems with Raleigh and South Memphis. We've got some serious blight problems in this city. At one point in time, the data was in the neighborhood of 22,000 vacant properties. I can tell you now that's double probably in all probability now, double or triple.
I can't give you a statistic for all schools, but what we have done is we've taken the data that we showed with the likelihood of a property being blighted, and then used that to map the city's school system around it, so that you can then get a figure of by some school districts what the likelihood is. And I can't give them to you offhand, but we do have that data and that information. Some other things that I would just touch on that we've been able to look into with the help of the University of Chicago has been what is the impact of a blighted property on the surrounding properties around it. There are they looked at sort of three outcomes, right? If you have a property that's blighted, you either keep the status quo, you tear it down, or you rehab it. And we're able to sort of gauge that impact on, and it's about a 250-foot radius of how the economic impact that it will have on surrounding properties. But you can actually, they've created another tool that I didn't get time to talk about that actually shows what investing in a blighted property will do to the property values surrounding it. It's kind of interesting work. So certainly thinking that way.
Professor, I also want to thank the U of M Law School and you for using our court with your law students to help in the Neighborhood Preservation Act cases. Those cases are very difficult, very complex, and they have done an unbelievable job under the tutelage of you and this guy right here.
Thanks,
done a great job.
Thanks, Judge. Let's move along. That's the end of section 1. We're moving on to section 2 now. We have Christina, Janet, and Otis are going to be talking about various the areas that they touch on in which policies related to healthy homes are coming into play. Go ahead. Let's go Christina, Otis, and then Janet.
Absolutely. Thank you. So first, thank you to Amy Campbell for putting on this great symposium. It's been a lot of wonderful information, and thank you for the invitation to speak on behalf of the LeBonheur Champ program. I want to take a quick poll of the audience first. By show of hands, how many of you either have asthma or know someone who has asthma? That's about accurate. 1 in 12 individuals have asthma in the United States. What that looks like for Shelby County is that in monetary terms, that accounts for $25 million annually for asthma-related ED encounters and inpatient stays. On the pediatric side of things, where I'm focused, that accounts for about 4,800 ED visits annually and close to 500 inpatient stays for pediatrics. So what we saw at LeBonheur back in 2013, we were awarded with a CMS grant to look at or to help children with high-risk asthma manage their care. And through that, this is an innovation grant, so through that we said that we would reduce the overall health care costs related to asthma, increase quality of life, and reduce ED utilization. That was back in 2013. We've enrolled 500 patients in our program, all TennCare patients, all high-risk asthma patients. And I'm happy to report that we have seen a 35% reduction in cost across board for these patients, and I'll tell you how we do it. First of all, we send them to our specialists at LeBonheur in our outpatient center to get the best quality care and appropriate asthma action plan. We also coordinate those services within the school system that they go to or the daycare, and also with their primary care physician. And if they do not have a primary care physician or a relationship with one, we help them to connect that relationship. And we share that asthma action plan with all parties involved. We also have, which is what I deem our greatest stride in this, is our community health workers. This is a dynamic group of young women who go into the field in the homes to address any social barriers that these families may be facing in order to manage the child's asthma in the home. So we saw a pyramid earlier addressing the social needs. And what we like to use in our department is Maslow's hierarchy of needs. So you know if you don't have your basic needs, your food, water, shelter taken care of, you're not going to reach to self-actualization. So we send our community health workers out to address those needs. So some people may think we're in the business of managing asthma, but we're really in the relationship building industry, because we build relationships with these families to make sure that they are connected to the resources that they need, whether it's utility assistance or if they have a mold issue or a water issue. We connect them to the different resources in the community so that they are able to kind of meet that need. On another side of things, focusing on the environmental and housing issues, I believe it was back in 2011, a survey was done by the American Housing Survey that showed that 26% of renter-owned properties here in Shelby County are below standard. That's compared to 11% nationally. We don't have the resources at LeBonheur to combat that issue, but we have a lot of other organizations that are taking on those issues. So what we have done is we work with Amy Campbell and her students in the School of Law, and they provided some very in-depth case studies for us. They met with a few of our families last semester to really assess what their housing issues were they related to in any way legally, and were there any kind of ramifications that they could do on their behalf. We also were represented on the Healthy Homes Partnership to collaborate with services to make sure that every child in this county grows up in a healthy home. So when you think about it in the broad spectrum of things, the numbers have shown that we are significantly reducing the overall healthcare costs. We're increasing the quality of life. But you can come into our specialists, our outpatient facility, and get the best care possible. But if you're still going to a home that has mold issues, water issues, rodents, pests, that is simply just putting a Band-Aid on a gushing wound. So we turn to the experts in those environmental and housing areas for assistance. And when you talk about, I heard someone mention silos earlier, what we're doing is really working to connect those groups because we all have a part in it.
Thank you. Well done. Thank you. Let's move around and notice. Thank you.
It is a pleasure to be here, and when I was asked to be a part, you do your studies and you find out some things that you really didn't know. And I found out a lot of things about healthy housing and contacting the National Healthy Housing Standard. We did a study between their codes and the codes of Memphis and the International Property Maintenance Codes. And we come to find out a lot about Memphis laws as it pertains to housing codes. We are somewhat behind, but we are still, can't hear me? I'm sorry. We are somewhat behind in certain areas, but in other areas we are above the national standard. I come to find out in my 18 years in this business that inspecting houses open your eyes to a whole lot of things. And I can say that there are probably some of us in here that are living in an unhealthy house and may not know it. We find that some houses are dilapidated, decayed, unsafe, and unsanitary, and how does that affect us? It causes sickness, disease, injury, health, moral safety, and general welfare to fall down. I've seen situations where children trying to do their homework in an unhealthy house. How does it affect them? I've seen where families are just separated from each other. Even though they're in the same house, there is no communication because of the living conditions. It has a moral effect mentally on people. I'm trying to make the best I can in the conditions that I can. And sometimes it's not just with those that are financially unable. I've been in houses in some of the most financial lifted areas of this city to find that they are infected with mold in the walls, that they have problems there that really affects people's health. So we get to that point, and the concept of what we're doing now in code enforcement, as Judge Potter talked about the number of houses that are blighted in the city of Memphis, he was correct. It's a little bit over 49,000. We wouldn't think that, but it is. So what we're doing now, we are educating, engaging, and enforcing the code of ordinance. When we say educating, because I found that a lot of times people don't know that they're living in substandard conditions. People don't know that they have created some hazards for themselves. As my director says sometimes, she didn't know that it was against the code of ordinance to have a sofa on the porch. It is. But it's also unhealthy because, as many of us know, that when that sofa is made, they treat the frapper with that Scotch Guard covering so it won't get stains. That's not meant to have direct sunlight. When it gets direct sunlight, it gives off gas and vapors. And if a person is sitting outside on it for a long period of time, they begin to find out that they're not feeling very good, where you're sitting in a toxic situation. We engage with people about storing materials. If you're painting, you have some leftover paint. You might paint one house in an oil-based paint, another house in a watercolor paint or whatever, and you store them all in the same area. Different chemicals. Don't let it be any heat around. So sometimes we create unhealthy situations in our own house. So that's the education part, where we can educate people about areas in which they live in. The engagement part is that when we come into these unhealthy situations, we come into these areas where the codes are in violation, we find out who is the responsible party. That's when we find out that the property is probably rental property. There are some conditions there that are dangerous as far as the structure itself. It may not have adequate heat. It may be exposed to the elements. And sometimes people are just trying to make do. So we engage to find out who is exactly responsible. One of the most difficult things that I have had to do is to come into somebody's house that called me there for help. And I have to tell them that the ultimate solving of your problem, I might have to vacate you out of the place where you're living. But we have many agencies in the city now that has came aboard to help individuals in that particular situation. So when we get to the engagement part, if they do not come into compliance, we go to the enforcement part. And the enforcement part is to bring them before a magistrate, bring them before the judge. I've been knowing him for going on 18 years. As a matter of fact, when I came into the ministry, he gave me my first robe, and I still use it. The enforcement part is sometimes a difficult part because it is very easy to come into Memphis and buy property and live in Seattle, Washington and never see it and receive money every month for it. That is a part that we are working on now, to change those laws, that we have some teeth in it, where we can actually reach and touch people, even if they live across the country, that they come to Memphis and earn profits off of their properties, but do not put back into the community. If you're like me, my home is the most valuable possession that my wife and I have. It's the most valuable investment that I have. And actually, my property value has went down because of blighted property in the neighborhood. When rental properties are popping up all around you, your property value may have a tendency to go down, especially if the responsible party lives out of reach and he's not investing to keep that property up. It really hurts sometimes to talk on the phone, and I talked to a gentleman about a property that he told me he was in Jamaica on vacation and he didn't got time to listen to him. But people were living in dire straits. So we're reaching out and we are touching the legal community to change those things, especially with the Neighborhood Preservation Act. And I just want to thank these guys for their due diligence in that, and it's going to change a whole lot of things. Thank you.
Thank you.
Very good.
I want to thank Amy and Danny Shafson for inviting me here today and allowing me to participate on behalf of the Shelby County Health Department. Several months ago, the Labana program, CHAMP got in touch with us. Kathy Marcinko got in touch with us and asked if the health department would be interested in collaborating with the City of Memphis, with the CHAMP program at Labana, and with, actually there were a couple of other groups. There was MALS involved there and some other agencies. And this gives the health department an opportunity to maximize our resources to be able to get out and do some very concrete things with the help of law students, because we've got to make some changes. We do have good laws on the books. One of my legal externs, Tom Wall, I want to make sure we give credit to him, did a little bit of research for me several months ago, and the truth is we've got some effective laws that deal with the condition of housing and holding people accountable, but there are just not as many teeth in those laws as we'd like to have.
And the state of Maryland has got some laws that have a little bit more effort that we can take in enforcement to take to Judge Potter and make a landlord do something that they wouldn't want to do. And it helps to have this collaboration because we get the data about the individual children who are impacted by these homes. Because it's not very important for us to say we want to change laws if we can't bring somebody a face with the problem. And it takes having those statistics and having the need tug on the heartstrings of legislators. Make them remember who they are accountable to and who they ultimately work for. Because as you saw in the prior part of the symposium, that legislators make a difference. And you really do have to get out there and vote. And you have to know who you're voting for. And that can make a difference. Because if you've got uncaring legislators, then you're going to wind up with a wider divide than we already have between those who have and those who have not in every community. But it's essentially a big part of how we live here in Shelby County. And we want to make sure that those children who cannot vote, who don't get to go, are going to be able to have somebody who's on their side to require that the homes they live in, they didn't choose to be in those homes. They didn't get to go shopping for them. They don't earn the incomes that cause them to live in a particular place. Those children are the ones who are either the advantaged because of their parents' choices or the disadvantaged of their parents' circumstances. Either way, you have to be aware that you've got a little victim who's waiting at the bottom of that chain, and they're the ones who suffer. And the other piece that Labana brings to the table is they help us to recognize that with those children, you've got a cost of health care. And that cost of health care, and we've got a cost that goes to the education system and the things that those children may not be able to accomplish. And I think about this a lot because if you're a woman of childbearing age, if you're a father thinking about parenthood, you have in your mind a child that comes into this world perfect. It's going to have fabulous 10 little fingers that can play piano. It's going to have the cutest little head. It's going to have perfect everything. Well, think about the child who comes into this world perfectly formed and situated, and then because of their housing conditions, they are deprived of what they could have been because their start was with everything that they needed. And the health department already does a program with the city of Memphis and with some other areas in Shelby County Division of Housing and Head Start to go out and test children and force landlords to make changes to properties that have a lead poisoning hazard. It's a significant program. It goes back to 1992. We instituted it here in 1994, and it's made a huge difference. And based upon that work, we have nurses that work in there, and we have assessors that work there. And Mr. Tidwell knows that we go out and we highlight the problem, and they force the people to get in there and clean up the house, to make those changes so that, and it's very expensive to remediate a home with lead poisoning. And that comes in the form of paint. And if you've never seen a child who has some sort of a condition where they eat paint or they eat pica, then you're lucky because you have to worry about the nutritional needs of a child who will take peeling paint and eat it. So with the help of the law students,
with the help of LeBonner, with the help of Mr. Tidwell, we want to create a set of laws that has the enforcement potential to go back to Judge Potter and be able to make those remedies, to be able to make those changes. The Public Health Department is about enforcement, about using our epidemiological evidence, and using those public health tools to make sure that the families are educated, that they make that they know who the connections are to call up and to see. But the one thing we want to make sure when we're doing this, everything about law is a balancing act. We don't want to make the laws so unfavorable that we have people that walk away from properties or who send it into an area of gentrification so that they can't make just the simple remedies, because we don't want to displace that many people from affordable housing. We want to make all housing in Shelby County a safe house for a child to live in.
Thank you all for being so cautious with the time. I know that you have a lot to say, and I know that you have a lot of things we'd love to hear. And we're trying to move right along. Do you all have your presentation already up on here? Amy has it. Okay, well, we get to move on. In the interest of time, I think we're going to hold up on questions for now, unless anybody has just a burning question for one of our group. Does anybody? I think that most folks will be able to stay around a little bit afterwards if you have questions. Do you want to go ahead and get started while she's setting you up?
Can you see, can I advance it on this one, please? Great. Good afternoon, everyone.
I guess I'm what's in between you and happy hour, right? Friday afternoon. So I'll try to be sitting lady. So this module is about the intersection of land use planning and public health. And John Zena, my co-presenter, we're actually going to talk just a few minutes about a specific plan that was done recently called Greenprint 2015-2040. And I'm going to tell you a little bit about the plan and the planning process, and then John, we're going to do a little bit of a deeper dive, and John's going to talk about the health perspectives of the plan. So so Greenprint 2015-2040 is the final plan of a process called the Mid-South Regional Greenprint and Sustainability Plan Initiative, which is a mouthful. And basically what that was is it was a planning process that was funded by the U.S. Division of Department of Housing and Urban Development. Shelby County got a $2.6 million grant, and then the Office of Sustainability, which John directs, is actually managed the grant process. And the purpose is to to enhance regional sustainability and basically to establish a unified vision for the region for a network of connected green spaces, otherwise known as the Greenprint. And the purpose of it is that there's a number of things that the plan is designed to address, including housing and land use, resource conservation, environmental protection, access to transportation, community health and wellness. As you can see, it's really a multi-faceted plan. It's called the Greenprint, but it's as you'll hear, it's about a lot more than green things. And so it was a regional plan that was, the planning area was all of Shelby County, a little bit of North Mississippi, East Arkansas, and a little piece of Fayette County, and then all of the municipalities within that. And one of the things that's distinctive about this is we don't have there's not a lot of planners in the room know there's not a lot of regional planning going on in our area. One of the reasons is that we're in a 3-state area, and so there's a lot of times more competition than there is cooperation. So this is unique from that perspective, in that the region really came together to develop this plan. So it's, as I said, it's a 25-year plan that is designed to, it envisions a region of connected communities that are united in creating a high quality of life so the region is sustainable, and so where all people can access abundant economic, social, and natural opportunities. And there's a couple of sort of parts of the vision that I just want to tell you about, because John actually led this, but I was very involved in it too, so I feel I'm not the only one, I realize, but I feel a real pride and ownership and sort of think this is my plan. So there's a couple aspects of the vision that I want to just tell you about, because I think they're important. The first is everyone's included in decision-making, including traditionally marginalized populations. Everyone, including people who live in low-income and minority neighborhoods, have access to all kinds of transportation, including transit, greenways, bike, and other things. Social and economic disparities are reduced. Everyone has access to health care and quality foods. Housing and transportation costs go down. More people are close to trails, schools, and parks. Everyone has safe and walkable neighborhoods. So you can see there's more, but you can see that this is a very lofty vision designed to articulate very specifically the kind of region we want to live in and how we think we can get to that region by building out this network of connected green spaces. So the planning process itself was managed by the Office of Sustainability, as I mentioned, along with a consortium of 80 organizations and 300 individuals that came together. I keep forgetting to advance the slide. They came together to plan it over a 3-year period, and this just really wrapped up about 6 months ago. But it was a very long planning process. So the process began with a vision, sort of laying the foundation. But in addition to the green, the planning, the specific network itself, and I'll show you a little bit of a piece of the map in a moment. There's also a number of studies, very specific studies. There was a bus transit to workplace study. There was a fair housing equity assessment study, and there's also a health impact assessment. And that's what John's going to tell you a little bit more about in a minute. And how which is particularly relevant to our discussion today, I think. So, social equity and community participation were really key to this. More than 4,000 residents from throughout the region participated in this process. This was a part of the planning process that I was involved in, and I can assure you that we went everywhere. I mean, churches, neighborhood associations, Rotary groups, garden clubs. I mean, every nook and cranny of this planning area, I think, was covered somehow, and we're very proud of what a good job we did in really reaching out. So I know you probably can't see this very well, but this is really the concept map for the regional network of connected green spaces, and it's the core element of the plan. With this plan, once it's all fully implemented and built out, I mean, not only are we able to provide a world-class green space amenity, but also address some of those vision principles that I talked about a minute ago, which would be, lower housing and transportation costs and full participation from everyone in planning, access to transportation, et cetera. So the scale of the network is really unbelievable. The plan calls for 499 miles of greenway trails, which is something like 10 times more than we have now. And I think we're very rich compared to a lot of places in terms of greenways, but the plan calls for really 10 times more. And then 196 miles of road connections, and that's bike lanes, pedestrian walks, all that kind of thing. But the plan's been a lot more than just connecting green space. It took a lot of other factors into consideration, like where people live and where people work, hence the bus transit to workplace study and other sources of data. So the network is designed not just to connect green places to each other, but to build a network so people can use the network, the green network, to get where they need to go. So much more, I guess much more than just, we think of green green spaces, sometimes it's recreation. We're really talking about building a network, a transportation network that people can use for recreation, but also to get where they need to go, and safely in a high-quality way and less expensively. And there's there's recommendations and action items in each of these areas. Housing, workforce, transportation, health, sustainability, all kinds. Each of these areas, and for each of these areas, there was a working group with government, nonprofits, citizens. So each of these, so it was very much not a consultant and top-down plan. It had a lot of, as I said, 300 organizations or 300 people in 80 organizations served on these working groups, and so I think John, when he comes up, because he's next, will tell you what the website is if you want to. Greenprint.org.
Yeah.
Okay, we'll tell you more about the plan itself. I encourage you to check it out because we're just scratching the surface today. So, John, you're gonna.
Thanks, Emily. I'm John Zena. I'm going to wrap it up by talking about the health impact assessment element of the Greenprint that we conducted. So these strategic directions that were part of the plan, one of the kind of key themes that we had that we carried through the whole planning process is that each of these areas aren't just sort of standalone, that there's a lot of interdependency among all these areas. And so as we sought to encourage the consortium members in coming up with recommendations for the plan, to think about those interdependencies. It was really important for us to be able to have some additional capacity behind the planning effort, to be able to think about how people get to work. So through that transportation work study and what that means for not just recommendations within the transportation section, but also the workforce section as well. And health impact assessment was one of the elements that we did as part of the regional plan, exactly for that reason, to really illustrate the interdependency between all of those different strategic directions that we had in the plan with health. And health impact assessment, if you're not familiar with it, is it's a methodology that's really growing in popularity, really, I guess, all over the country and North America. And it's a great way to apply a health lens to a decision that may not necessarily have health as sort of a top priority or even sort of a key goal or key outcome. And I think we're seeing it a lot in planning and in work related to built environment because there's just so much more discussion that's ongoing related to the health of people, the health of communities with respect to the places they live. And of course, everything you've heard before Emily and I came up here certainly underscores that point. In addition to sort of the visioning and process of the consortium and of the planning effort, this health impact assessment really kind of helped bring that backbone to the health section of the planning effort. So there were 4 main components that we did as a part of our health impact assessment. The first was to do a preliminary report on the baseline conditions of health. So really just to kind of go through a detailed look region-wide at factors of health outcomes like chronic diseases, but also key indicators like leisure time physical activity, where we found that across our region, 30% of our population gets 0 leisure time physical activity in their day-to-day lives. But also, in addition to that, we found that a lot of our region doesn't have nearby access to green space and other public spaces where that leisure time physical activity might be convenient for them. We also found that we have a high incidence of chronic diseases that are linked to healthy eating behaviors, but we found that over 30% of our region has low access to healthy foods. So a lot of these things are obviously very well connected. So it was important for us to do this preliminary report of the conditions before we got into the process of the HIA to really know kind of what we were working with in terms of not just the health outcomes that we see, and that I think we know about in terms of headlines, but also the health indicators that really can start to explain why we have such high health disparities within our region. And so the full HIA report obviously was kind of the second major component and the largest major component. And this really helped us kind of shape a lot of the recommendations that are in the final plan. But we also wanted to take the methodology of HIA, since this was really one of the first HIA projects that we had done in the region that really I think anyone had done in the region, and be able to document the process and the tools that people could use to be able to conduct HIA on their own, and house that on our website. We also held a workshop training for about 40 individuals as well, to really understand how the process of HIA is used and how it can be applied to decisions that they were working on in their day-to-day lives. And then we also wanted to apply HIA to sort of a smaller scale project. Obviously, the Green Current region is pretty large, and so we wanted to look at how it could be applied to a neighborhood scale. As part of the Green Grant, we did 20 demonstration projects that were more localized, that sort of applied the regional concepts to the neighborhood scale. One of those was in the Fraser neighborhood, where they did a design plan for a town center. So we did a rapid HIA for that project to really think through sort of the health implications of the community's selection of where their town center might be located. So I guess the process of HIA sort of follows a screening. So understanding, is HIA appropriate for this type of decision, scoping out what the assessment would look like, sort of assessing the background conditions, and that preliminary report of baseline conditions served as that, and then recommendations. And obviously that was where the bulk of our work went related to our HIA. Because we were really focused on that interdependency of health and all these other elements within the Green Print and the working groups, we had an advisory committee with representation from each of our working groups, so that we weren't just kind of focused in on the people who were already kind of zeroed in on health, but also we could bring in people who were more interested in workforce development or parks and greenways. And with that advisory committee, made some decisions on some specific actions within the plan to focus our attention for the health impact assessment process. So I'll give you just a couple of examples, and then I know we got to wrap it up. But just in terms of how this process gets applied, so this action, retrofit auto-centric corridors to be more bicycle and pedestrian friendly, was one of the primary recommendations that we had come out of the transportation group. So as we went through the process of just looking at the assessment, understanding how health is sort of applied to this. What comes out of it is that what we perhaps need to also be thinking about is safe designs for on-street and off-street facilities. So thinking about if you're taking an auto-centric corridor, you want to make it more of a sort of friendly environment for bicycles and pedestrians. Most new cyclists, and really a lot of pedestrians too, they're likely to use a dedicated trail that's doesn't interact with automobiles. So you need to make sure that you consider that in on-street design. So we did things like the Complete Streets policy that was actually predated the Green Print, but we did a design manual as part of the Green Print. You got projects like the Hamp Line, where you're separating bicycle paths from the automobile traffic. So those types of strategies can be used on-road, but also when you're thinking about off-road, you need to consider creating off-road environments that are safe for all users, particularly thinking about the range of ages and abilities of people who may be using those trails. So right now, take, for example, the Shelby Farms Green Line, extremely popular. Not a lot of areas where people can rest. So, if they're limited in their ability to be able to take advantage of that, perhaps an intervention to sort of create a healthier environment for all people would be to think about, how can you integrate some rest facilities along a trail. So thinking about, what you can do in terms of being able to serve all users, all levels of comfort, to not only create more pedestrian and bicycle-friendly auto corridors, but also off-road trails as well. So I'm going to wrap it up there. I know we've got, I had a couple more to share, but I know we're running out of time, so, and we certainly want to leave room for questions.
Thank you.
Well, thank you to the panelists for a great presentation, a great group we have. I wish we had a lot more time to talk. Everybody here, you should stay in touch with. This is a great team, and it's so wonderful for the law school to be the place where we're talking about how we can connect community development with wellness, and how we can do everything from getting rid of blighted properties to improve the pedestrian and bicycle safety of our community. I know that Amy has some things that she would like to do. I think I'm going to go ahead now, if you don't mind, Amy, and hand it over to you if you want to connect sort of some of the follow-up questions and discussion. And we're gonna move on to the closing session. Thank you so much.
We should, yes, applaud And unlike Emily Trenholm, I actually do stand between you and the happy hour, including my happy hour, so I am going to be New York fast.
New York fast.
Yeah, I know. My New Yorker attitude will come out now. One thing, I know we're a place of challenges, and no one mentioned barbecue today. And I think it was Mitch Shipman who told me I'm going to get in trouble for saying this, but I think one challenge is last night I went to dinner here, and I wanted something light, which is hard to eat here. And so I got a salad, a nice vegetarian salad that had, of course, an average topping, bacon, on it. And you can get a dessert where bacon is your dessert. I mean, I've never said bacon is just another condiment or dessert topping in this area. So, we have challenges with our culture, but I think we've seen today that there is a lot of opportunity. If we definitely, I think, can see in this room that we can easily catalyze the demand that was spoken about today to generate health. We have structural barriers, sure, but we have a collective will that we just have to harness and align and sort of coordinate in some way to have building blocks for a healthier community. And by building, we build up. I think we've definitely heard that there are great people in this room, but we're missing, obviously, a lot of people, including the people in the communities that we most need to help and work alongside. So how can we do that? The blocks, Overton Square is great. I love Babalu. But how can we make that success story across our zip codes, and not just think that because a few zip codes are doing well, that means that Memphis and Shelby County is doing well? How do we think about that? I think it's going to take active listening, and I had said we want to open our doors for you to come in here. We also have to go out. How do we go out, work with our faith communities, work with, the different CDCs, and get out in the community and actually actively listen and say, what do you need? What does health mean? How can we align and kind of have a shared vision for what health means for you and what would be the goals of health? Collaboration we heard about, multi-sector. I really loved our faith panel. I think there's a lot of opportunity to work with our faith community here on that healing and reclaiming and the resiliency of our community, and working with them as trusted leaders. Not that me, as a lawyer from upstate New York, is not trusted, but perhaps I should also reach out to the faith community. For us, I think a focal point, it's what can generate interest and get people to the table. Our experience with the Healthy Homes Partnership is kids, children. It's not just about a code, it's not just about mold in the home, it's about kids' health. And today we saw a great visual of why aren't we asking our kids what health means to them and having them be invested in this community so they actually want to stay here and really invest in us, which I think would be great. And so investment takes planning. And we've certainly heard a lot about planning today. How do we be thoughtful about, we have resources, how do we be more intentional about how we actually utilize those resources? How do we prioritize? And maybe for some people in this room, that means you have to give up a little, but hopefully we can gain more. And so how do we have those conversations? How do we develop priorities? We've heard about mapping technologies. I love the dot maps we've seen. I know Dr. Wars at UT does a lot around community mapping, GIS, all these fancy technical things that lawyers aren't as good at, but they're providing us data with the stories that we can actually really move the map. And so how do we create ultimately an environment meant broadly, that promotes health, that doesn't cause stress, that actually relieves stress, and that the many forms. And I do, how do we create more Tennessee breweries, right? Throw in a little wine bar in there too, I'm sold. But, so how do we create more of those kinds of opportunities? So I end with just saying that next steps, first of all, I said this was the beginning of a conversation. I've been tracking my own data on all of you in this room. We want to continue the conversation with your permission. I'm not going to share this widely, but I've heard from a lot of people that it would be neat to see who was in the room and how can we continue this conversation at the law school, outside of the law school, with our many partners at the university, with our many partners in the community. How can we be involved? So we're going to be reaching out and rolling up our sleeves. I know we have some students who've been great helps already, but who really are eager to learn while also serving in this community. So consider us, if the city is a lab, we're your policy lab. So if you need research, if you need sort of the help, of our wonderful externs and clinics and all the things, we're here to sort of be the partner at that level and help as we can. So I guess I would just end on that by, my own thing. We heard about the calling. So for me, it's sort of a calling, I guess, as well, that we really are here at the law school to serve. And I always say lawyering is a service profession. So we want to serve well, serve in partnership and collaboration with you to really have law advance health. Law is not the goal. It's hopefully a tool and policy that can advance the health of our community. So we are thrilled to be part of that and to sort of help change systems. With that, I leave you. Good luck. I know I started with your brackets. May today have been a better day for any of you. Certainly for me, I'm out of it, but if Notre Dame wins, I'll be happy. But I thank you so much, and I applaud everyone for hanging in there today.